Welcome to the Core REMS opioid presentation. We've been lucky to give this our third time now. So we're all physicians here in Utah, usually between Utah and Salt Lake County. And we work with the Core REMS group to provide information on opioids, managing, monitoring opioids, risk and benefits of opioids. This is all done through a larger government process for approval. There's questions on the slides. Please let us know. Questions on the test questions. We'll go over those at the end. So no disclosures from any one of us?
Oh, except for me.
Go ahead, disclose.
So I have a interest financially, and I'm an unpaid consultant for, it's not a pharmaceutical company, but it's for a educational system. It'll be on my slide.
Yep.
It's unpaid.
Yeah, and then no disclosures related to the opioid community, opioid pharmacies, or pharmaceutical companies. So I'm John Benfield. I'm a physician in Utah County at Utah Valley Pain Management, board certified in physical med and rehab, and also pain medicine. Been in Utah for 4 years. Prior to that, I had a private practice in San Antonio, Texas. But I have a big interest in chronic pain, chronic joint pain, chronic spinal pain, opioid weaning, and electrodiagnostic studies. And then right to the left of me is Dr. Mathew Romankowski. Dr. Romankowski is in Salt Lake at the Salt Lake Clinic, and also sees patients from our clinic in Utah Valley Pain Management. He board certified in anesthesia and also pain medicine. Similar specialty interests that I have, but also into neuromodulation, and chronic pain, chronic joint pain. No. The next is Dr. Josh Minori, who's in the middle. Dr. Minori is a physician at Park City and Heber, lives in Salt Lake County. He's boarded in physical med and rehab, and also pain medicine. Has similar interests, but also previously was an athletic trainer, right, Josh? And then orthopedic research. So sees a lot of musculoskeletal complaints that are chronic, a lot of peripheral nerve entrapments that are chronic, and then some interest and expertise in regenerative medicine in the pain space, which is somewhat new and up and coming. So then many of you probably know Dr. Robin Ockey. Dr. Ockey was the founder of Utah Valley Pain Medicine and Pain Management in Utah County. He's the associate medical director at Intermountain Health for pain medicine. And I think kind of a national wonder when it comes to opioid education and all things chronic pain. So very nice to have him here and have him lecture with us. I know I can speak personally as a provider. He's usually on my speed dial when I have a tricky case that involves chronic pain or electrodiagnostics or opioids.
We'll pass that all over.
Yes. And Dr. Romankowski says we'll pass Dr. Ockey's cell phone out later. So is that showing up? Huh? Slides are switching on us here. Here we go. There we go. Let me get back in presentation mode. There we go. And so the Core Collaborative, it's a handful of different national groups that help fund and then make sure the opioid talking points and educational pieces we're giving today are appropriate based on evidence-based medicine. So I'd like to thank those partners. And then here's the Core Faculty Advisory Panel that meets again to kind of audit and check the information presented. So there's about 6 different kind of bullet points we want to hit through about 140 different slides. We'll start off going over some basic opioid concepts. Some state facts on opioid prescriptions, opioid deaths, some newer kind of public health issues we'll talk about in pain. Then what we'd like to do is get into the pathophysiology of pain for the first kind of meat and potatoes of the lecture, and that'll be presented largely by Dr. Romankowski. And then how to accurately assess patients both with acute and chronic pain, independent on if they're on opioids or not, and independent on where that pain is actually at. And then identify evidence-based non-opioid options, and also some opioid options. When are opioids appropriate? And which opioid is appropriate. And then if you identify someone that is appropriate for opioid therapy, how do you manage and monitor that patient for safety, for effectiveness of the medication and compliance to the medication? And then last, recognizing behaviors that are associated with opioid use disorder. That's not last because of important, it's a bigger issue that I think a lot of you will have questions on. But we'd like to, you're gonna be prescribing, managing, or monitoring opioid patients, understanding opioid use disorder, and how to take care of it and identify it's kind of imperative. So that's why we're here. The core statement here really has 4 main points. CORE was established to address the historical overprescribing of opioids, really in the 1990s up to about 2010, 2011. I think we all know, we all have patients where opioids are very effective for them. They improve quality of life, they improve function, but that has to be balanced with the risk of opioid use disorder, respiratory depression, and other side effects. We all know there's unintended consequences to every medication and procedure we do. Opioids, unfortunately, have a kind of a higher rate of that nationally when compared to other medications and procedures, especially in the pain world. The course is not for or against opioids. The point of the course is to educate you. So hopefully you can use this information in your practice on an individual patient by patient level. So when we look at opioids, we've seen some really good fluctuations in trends in opioids, really since they've been being prescribed and have gotten popular. Since we go back to 2010, it's been about 143 million opioids prescribed in the United States. That doesn't include 2021, 2022, 2023 data. Of those 143 million, there's been 94,000 that were addressed to prescription opioid deaths, with a lot of those actually being opioid deaths or overdoses where the patient was taking the opioid as prescribed. And I specifically highlight that because there's some bias that people that have overdoses or an overdose death with opioid must have been doing something wrong, either the provider, the physician, the mid-level provider, or the patient. And that's not always true in a good chunk of cases. Often, it unfortunately is a known side effect of a potent medication when both patient and physician were trying to do their absolute best to care for the patient's pain. We've fortunately seen opioid prescriptions really trend down. This since 2011, but it really is 2013, 2014 as where we've seen it come down. And we've seen it come down in Utah as well. We'll get into more slides with that. Unfortunately, though, we've seen overdose deaths from opioids go up, and that's largely due to illicit opioids, especially illicit fentanyl or fentanyl analogs. When we talk about opioids, there's a couple ways to describe opioids and classify those opioids. The top or maroon or red graph looks at how the opioid is made. So we have naturally occurring opioids like codeine and morphine. That includes Tylenol 3 and 4, and then 5 and 6 in other countries. We have semi-synthetic opioids. That's probably the main, meat and potatoes or big chunk of what we see prescription-wise. And that's your buprenorphine, hydrocodone, hydromorphone, oxycodone, oxymorphone, and then the long and short-acting derivatives of those. And then buprenorphine has many different formulations now. Then we have our synthetic opioids. And on that last slide where we see overdose deaths going up, it's largely due to synthetic opioids that are not methadone. Even though methadone is still a very, very scary and can be a tricky drug to prescribe and monitor, the large overdoses and overdose deaths we're seeing are largely fentanyl and fentanyl derivatives. And then we're seeing that go up, unfortunately, the last couple of years. And then you can look at them kind of pharmacologically. How do they work in your body? So we have the agonists, we have antagonists. That's true with a lot of medication classifications. We also have partial agonists, like buprenorphine and nalbuphine. Nalbuphine we don't see prescribed as much anymore. That's largely due probably to lack of familiarity and also insurance coverage of it. Buprenorphine was that way probably about 10 years ago. We are seeing better coverage of it, and we're also seeing more formulary types of it. So we have like the Butrans patch, right? We have Belbuca, which is a buccal tablet or chiclet or patch. And we have Subutex and Suboxone that are very similar, with Suboxone having naloxone in it. And then there's Zubsolv, and there's even Sublocade, which is an injectable form for opioid use disorder. So we've seen that category actually expand a lot in the last decade. And then we have our agonists, which are ones we're probably more familiar with, which are codeine, methadone, morphine, oxycodone. And then those have derivatives as well. We're all very familiar with the DEA scheduled drugs. We're going to hit medications in a lot of those. We have codeine, like codeine cough syrups, which are usually Schedule 5, I think we're all familiar with. We don't have a ton of opioids besides tramadol in Schedule 4, but we do have a large class there of benzodiazepines that interact, unfortunately, negatively with opioids. And so we'll spend some time talking about that. Schedule 3 is where we see our buprenorphine that we just saw on the last slide. Although ketamine is not an opioid, we're seeing it more used in people with mental health disorders or neuropathic pain, refractory neuropathic pain. So that's becoming a bigger player in the pain space. Then we have Schedule 2, which is where most of our opioids reside. And then Schedule 1 is important because that's where we see the illicit fentanyl. And then also medical and recreational cannabis and cannabis products are becoming a lot more common throughout the United States and world. And we'll have lots of questions from patients, you probably have in your own practices, patients who are curious how that interacts with their pain, with their opioid, how to use it. And obviously lots of state laws that interact with how much you can prescribe or direct or educate a patient on medical or recreational cannabis. I don't want to belabor the point, but I do want to highlight it. When we look at this graph, it really highlights the improved prescribing habits of natural and semi-synthetic opioids. We see that there in kind of the darker green. We see a larger rise in heroin between 2011 and 2016 because it was accessible, it was cheap, and it was a lot easier to obtain than other illicit opioids, whether that was fentanyl or black market or street like oxycodone or hydrocodone or morphine. That's fortunately been going down, which has been really, really nice to see. We see the same thing with methadone. Methadone is probably more a byproduct of, it can still be misused. It's used largely in this state for opioid use disorder or prior heroin use. There is literature on methadone being used for certain pain states, cancer pain, refractory neuropathic pain, sickle cell disease, and that varies state by state on prescribing habits. The large group that we see and the only group we see going up are those synthetic opioids. And again, that's the fentanyl and fentanyl derivatives that we're seeing being used illicitly. They're being mixed in other illicit substances. And we also have substances that people are buying off the street where they think it may be hydrocodone or oxycodone, but it's actually being laced with, or it's just fentanyl. And that's what's made that so scary. And you've probably seen several news clippings over the past year or two, even in Utah, where those have, unfortunately, they've either had fentanyl drug bust or people pass away from fentanyl. We've even had reports in the U.S. where fentanyl's been mixed with recreational cannabis, and we've had side effects and people die from that. So it's definitely a chemical we need to keep our eye on, and we really don't have an answer to right now, with the exception of making sure our communities have lots and lots of Narcan and naloxone in it. So that when you identify what appears to be an opioid overdose or misuse, you can administrate it. Reason fentanyl is so effective or so potent is obviously, especially when it's given IV, it's short acting, it's metabolized quickly, it offers great pain relief. We see it used a lot in our military soldiers in trauma situations. It's an effective medication when used appropriately. Unfortunately, it also kind of gives it the other side of the coin, where it also becomes a drug that's easy to feel euphoric on, especially when taken IV intramuscularly. The minus side, obviously, for us, not for those who sell it on the black market, it's cheap. It's easy to manufacture. It's easy to use as a substrate or a mix-in with other chemicals or drugs. Easy to store, smoke, and conceal. The dosing is highly unpredictable. I know here, and I'll say this, it says non-prescribed fentanyl. I think we've all heard stories, and we've seen in our own clinics, fentanyl, even when prescribed in a patch, is still heat sensitive. And you can even see fluctuations on how quickly your body absorbs that transdermal fentanyl on the temperature changes. You put a blow dryer on it. Did you wear it during a hot shower? Did you have it in a hot tub? Did you go into a sauna? And so we see some things, even with prescribed fentanyl, where it's probably more unpredictable than even other transdermal systems like Lidoderm or Butrans. So it's a medication to proceed with caution. It does have a place. I mean, we see it a lot in our ORs, our hospitals, and our cancer pain patients. But again, you need to have a healthy respect for all opioids, especially fentanyl. Two main causes of fentanyl overdose, I don't think would surprise us. One is opioid-induced respiratory depression. That can happen with any opioid, whether that's fentanyl or buprenorphine. It acts on those same receptors. There is variation, though, on which opioids act on certain receptor subtypes, and that can change its effectiveness, but also the potency of its side effects. The other one probably doesn't get as much attention as it should is rigid chest wall syndrome, where it inhibits the ability of your chest, especially when it's given IV, to expand and contract. So obviously that's going to affect lung function. So where rigid chest wall syndrome ends and opioid-induced respiratory depression begins in those cases, there's no well-demarcated line, but beware of both of those, especially if you're inside the hospital giving fentanyl IV, either intraoperatively or on the floor. We do see it. I unfortunately had two patients that passed away of this during COVID who had COPD, other respiratory issues, were on doses of opioids and were both given fentanyl in the ICU with their COVID pneumonia. We don't know if it was a cause of it, but it's definitely probably a factor that didn't help them, get off the ventilator. So just be wary of that. with all medications, there's potential risk and benefits. The pendulum has definitely swung, as you see demonstrated in the slide, towards potential risk of opioids, in most cases outweighing the potential benefits. The biggest ones are the life-threatening side effects of respiratory depression, opioid misuse. We have people that divert it for financial or other secondary gain factors. The one up there that I'm going to probably highlight, I'm going to highlight the most, neonatal abstinence syndrome. There was a case last week at one of our hospitals here in Utah, of an individual that came in on methadone, and that wasn't reported to the OB and the OB team, and so it created a code blue situation, both from the mother and the baby once born. And then inadvertent exposure to family and pets. And Dr. Ockey, we're lucky, he provides a weekly opioid education class to patients in our clinic that are either coming into our clinic or starting opioids. And one of the points he highlights is the inadvertent exposure to other people in the house. So this would be, opening your opioid at the, at the kitchen counter, and a tablet falls off and hits the floor. One falls in the kitchen sink. A lot of our tablets look like candy to our younger kids and grandkids. It's between 3,500 and 5,000 exposures per year, with a good chunk of those exposures each year ending in death of a bystander. Again, not because someone did something wrong, but a common situation turned lethal.
Those numbers are under the age of 6.
Under the age of 6. So yeah, it's probably the first time I attended Dr. Ockey's education classes 4 years ago, when I heard that statistic. That's the one that makes me curdle the most, just because it's a vulnerable population. They don't know any better, and it looks like a piece of candy. And that includes pets as well. And then obviously we know about physiological dependence and withdrawal. And we'll get into a lot of these terms. There's a lot of minutia that's good to understand between opioid use disorder, substance use disorder, opioid tolerance, dependence, and then what we used to call opioid addiction, which is now called opioid use disorder. There is clear potential benefits too. I think we've all either had surgeries, had patients with those, who've had certain surgeries where opioids are clearly indicated. Cancer pain's a big area. People with multiple back surgeries. So there is a place for opioids, but when prescribed, obviously to be monitored very, very, very closely. There's the ability for opioids to relieve suffering, to relieve pain, to improve quality of life, to improve function. And again, it's the risk-benefit ratio, and this lecture is really set up to give you that education. It's not to speak for or against opioids. I think all of us have patients in our practices that do very, very well on opioids. There's always the constant battle to keep them on the lowest, most effective dose. But we all have patients that they've come off, they've reduced, and they've seen their quality of life and function go down. We've all had patients where we've seen just the opposite, where opioids weren't right for them. So regarding Utah-specific rates, and if you want other states' rates or even data specific to your county or city in Utah, the CDC has a great website on this, and you can even search by zip code, which is really nice. So Utah as a whole, and it does vary a lot by county in Utah. What's that? Okay. So 2018, 57 people per every 100 had received an opioid prescription. That's over half of, it'd be half of us in the room, over half of us would have an opioid prescription. Very, very high. What this isn't showing, but which we teach in our practice, is not only were we prescribing more, if you broke that up into opioid by milligram morphine equivalent, so 20, 50, and 90, we were also prescribing higher doses more often. So it really was a scary situation. Utah has done a very good job on this, though, because that's come down in 2 years by almost 10%. And I'm curious to see 2021 and 2022 data. Oh, go ahead.
Are those numbers the number of opioid prescriptions divided by the number of people, or is it actually per 100 people that number of them get an opioid prescription or multiple opioids?
Go ahead.
Yeah, so basically it is the number of prescriptions per 100 people.
Yep.
So it could be a lot of people are getting more than one.
Yes.
So in other words, you may only have 20 people or 10 people
Right.
getting prescriptions. Okay.
Yep. But and that's why we said yes to both, because the CDC and state and hospitals really struggle separating the person that gets maybe 7 days of opioids, right, for say, I don't know, post-TKA versus the person that maybe has 2 short-actings and a long-acting from someone who's overprescribing. And that's where there's a lot of minutia here in data that I wish we had, and I wish we even broke it down by opioid and by how long they're on it, because that matters too. But yes, yep. So it's a mixed bag here, even though it's how they're comparing apples to apples across states. So, and then the bottom section is opioid overdeath rates per 100,000 people in the population. And so Utah, this doesn't show, I wish the group that did these slides showed this. Utah has also been trending down on this. So Utah has done a very good job in trying to mitigate opioid risk and overdoses, probably since the last, 5 to 7 years. We've seen some really, really large improvements from, physicians and mid-levels in our state and also the health systems.
Is that prescription overdose, or is it all?
This, remember, is overdose deaths from all, from my understanding. And that's why that one slide I showed at the very beginning, we saw prescription deaths going down, and we saw the overdoses going up. That's again because fentanyl is really, illicit fentanyl and other synthetic opioids have really increased a lot the last 3 to 5 years, exponentially each year. Okay, I'm going to turn over to Dr. Romankowski.
Well, thanks for having me here, you guys. I'm Dr. Romankowski, did anesthesia residency, and then further subspecialized into interventional pain, multidisciplinary pain. And in my fellowship, I was introduced quite heavily with neuromodulation, so I have a very big interest, as Dr. Benfield said earlier, in treating pain outside of just medications and having it be part of the armamentarium that can really, change quality of life in a lot of patients. So that's just a little bit of my background. But this portion here, let's see, wrong way, is about pain, believe it or not. So usually people are on these opioids typically because of some sort of pain, right? But we'll get kind of back to more of a didactic of what pain is. And I show this slide first, and these are a little bit out of order, I think, because if we're talking about pain, we should have a definition of pain, right? So the IASP, or the International Association of the Study of Pain, has come up with a definition, and it's one that we kind of follow from specialty to specialty, even throughout medicine in general. And pain is really defined as an unpleasant sensory and emotional experience associated with or resembling that associated with or actual potential tissue damage. So the big points of that are that it's sensory, but there's also a very large emotional component to it. And so we can never forget that that is part of a patient or an individual's experience of pain. So this, more about the neuromechanism of pain. So just as an example, how they provided this is, let's start with an injury. So this person stepping on a tack, that's a nociceptive, painful stimuli that they're experiencing. And what happens then? So that painful stimuli somehow gets up to the brain and we feel pain, right? But it goes through a process where it first travels along sensory neurons. And the main ones for pain are the A delta, the A beta, and the C fibers. The A delta are really this first response. They're thinly myelinated, very quick acting, localize pain very well. And so it travels down through an action potential down to the spinal cord, where it'll synapse at the dorsal horn of that spinal cord. After it synapses, it decussates and then goes up the spinal thalamic tract here up to our brain. And so where does it go in our brain? A lot of different places in our brain, but really into the thalamus and the midbrain and the periaqueductal gray region. So with the thalamus, how that's kind of responding is sending information over to the somatosensory cortex, the parietal lobe, the frontal lobe, and then also into the limbic system. And all these different areas help us process, understand, sense what's going on in our environment and happening to our bodies. And that's the transmission in our experience. That's part of it. The limbic system, really important for emotion, especially in the anterior cingulate gyrus region. And we can go into a little bit more on this next slide, but throughout this process, after it hits the brain, so then we have a way to kind of modulate that. Our body does it in and of itself, but with different neurotransmitters. And so these neurotransmitters and these descending neurotransmitters, predominantly norepinephrine, serotonin, endogenous opioids like enkephalin and beta endorphin, and others like GABA, NMDA. All of those things can help our body to understand that pain and decrease the amount of pain once we've sensed it. And in the periphery, the next slide shows it a little bit better, but histamines, prostaglandins, so on and so forth. This is kind of an example of that same injury. There's tissue damage somehow, some way, right? So mechanical, thermal, chemical damage, and that then sets off this cascade. We release histamines, bradykinins, prostaglandins, potassium, CGRP, substance P, all excitatory in that periphery. Those then go down those same nerve pathways through the dorsal root ganglion into the spinal cord. Feeling physical pain, as the slide says, is vital for survival, but pain is the body's early warning system. Unfortunately, there can be some upregulation of certain things like sodium channels and a downregulation of potassium channels, which then can lead to peripheral sensitization. Over the course of time, that upregulation can then lead to a chronic pain state, and they can spontaneously fire. And so we have this development further centrally to form central sensitization. So we get into these chronic pain states where these nerves are aberrantly firing, so to speak, and causing, day in, day out pain for some individuals. Any questions on that stuff? Okay. And so opioids. We're here today to talk a lot about opioids, but also other ways to help treat pain. In this slide, it's really just saying opioids, we have receptors pretty much everywhere in our body. Throughout our intestinal tract, that's why constipation is very prominent in opioid management, in opioid treatment, something we never want to forget about. And then also a lot of receptors throughout. So in that spinal cord, there's different lamina, or rex lamina is what they're called. And we have mu receptors scattered throughout, mainly in lamina 1, 2, and 5. In lamina 2 is the substantia gelatinosa. So a lot of the opioids that we treat, even from an anesthesia standpoint, intrathecally or epidurally, will go right to this center. And that's a main kind of pathway for us to use it for pain from an anesthesia standpoint. Up in the brain, we have the nucleus accumbens, which is our center for euphoria, unfortunately, in some individuals. And then the periaqueductal gray also has the locus ceruleus, and those two centers are about decision making, but also with not only decision making, but also with pain perception and regulation. So very important structures in our brain that have receptors, mu receptors. What we would love is if these opioids that we prescribe went straight to the periaqueductal gray. That's that pain. It's about decision making, but more so with pain and processing of that pain. Unfortunately, they also go to the nucleus accumbens. And like I said before, that's that sense of overall well-being that some patients will get when they have an opioid, but also with a euphoric type of state. So someone that is baseline hedonic, they receive an opioid, they might get a very big response in this nucleus accumbens, and that would probably put them at a higher probability of having an addictive type of behavior, because that euphoria is a big driver for that. So then these slides talk about what IASP says the definition of pain is, which I already said. It might be nice for you guys to read it as well. But it's the and in there, sensory and emotional experience, that I think is very important. States of pain, so acute pain, usually the duration is less than a month. Sudden onset, self-limiting, ideally resolves with healing, triggered by that tissue damage that we just went over. Has protective value because you don't want to put your hand on a hot stove because your body's gonna tell you immediately that's not good, right? So it can have a protective value, but we need to manage it, monitor it, and treat it appropriately so that it doesn't turn into a chronic pain state. Subacute pain is usually between 1 and 3 months, and then we shift over to that chronic pain state, which is lasting 3 months or longer on average. I have a little buffer there, but we can talk about that on the different types of pain later. Generally, steady state or worsening persists beyond normal healing period, serves no value, and peripheral and central sensitization, which we briefly touched on. So what are the types of pain? We have nociceptive or inflammatory. That was our guide initially to go over the basics of pain. And this is painful response to a stimuli, chemical, thermal, traumatic, all of those. And these are postoperative pain states, injuries, you fall, break your arm, those type of things. Sickle cell disease is listed in there. And then mechanical low back pain, like very descriptive. We have facet arthropathy or we have disc-mediated pain. Those are nociceptive type pain syndromes. Then we have nociplastic. This is pain that arises from altered nociceptive function, typically chronic. And the IASP also states that there's no particular tissue damage or identifiable factor that's causing it, but there's still pain coming from it. And these are states like fibromyalgia, IBS, and nonspecific low back pain. Get your x-rays, your MRI of your low back. We don't really see any cause of your low back pain, but you still have it. So that's kind of a nociplastic type of pain. Neuropathic pain, diabetes, we think about. This is pain that develops when the nervous system is damaged and it becomes chronic. So postherpetic neuralgia, trigeminal, CRPS is in this, although I would kind of argue that CRPS is kind of a mixed state in some cases. And then there's neuropathic low back pain as well. And then mixed. So primary injury, secondary effects. So it's not this all the time very clear-cut way of describing someone's pain. There's usually different factors and qualifiers that you find with a really good history, and that can lead you down different treatment algorithms. So I think it's very important that we know what they are, but also know that it's on a continuum, so to speak. Biopsychosocial model, extremely important in all of the patients that you're treating, I'm sure, but especially in the pain population. There's a lot to be said about treating that patient as holistically as possible, because pain in and of itself affects not only your mental, your physical, your spiritual, your psychological well-being, but also how you interact with everybody in your space. So we like to practice a biopsychosocial model because it integrates all of those characteristics into treating this patient as holistically as possible. All of them can either worsen or improve function. And then this is a newer slide that was added this last year, but adverse childhood experiences. So a shift of focus. We don't want to say, what's wrong with this patient, but what has happened? What's the experience of this patient? And that takes into account all of these different things here that you see listed. Unintended pregnancies, education, alcohol and drug abuse, either with themselves or in the home, or a family member, depression, anxiety, suicide, PTSD, huge in pain. We know quite extensively that mental health states, like depression and anxiety, can worsen pain states. They're directly correlated. So a little bit about terminology here. Words matter, and this is a nice little quote here. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed. So we used to say addiction, when you're seeing a patient in clinic, you really want to be as careful with your wording as possible and show empathy and compassion throughout each step of the process. And that comes a lot with how we speak with patients. We're taught in medical school, limit your jargon, your medical jargon, so that we're on the same playing field, right? And this is true when we're dealing with pain and even with opioids in particular. So we don't want to use addiction. We want to use substance use disorder or opioid use disorder. Drug seeking or aberrant problematic behavior. That's tough for a patient to hear aberrant behavior. I've made that mistake before, and I kind of learned from it very quickly that that was very threatening. So you just want to be as direct as possible, but also be very consistent with what the issue you're seeing is. So you weren't using your medication as prescribed. Let's talk about this. Instead of, this is problematic behavior, this is aberrant behavior, I'm throwing the hammer down type of thing. Addict or user, maybe a person with substance use disorder. Dirty urine, failing a test, you're testing positive for things that maybe aren't on your list of medications, and we need to talk about this. Abuse or habit, misuse, or use other than prescribed are easier ways to kind of address these. And then definitions to some of the things that we talk about. And Dr. Benfield talked about misuse, tolerance, dependence. Misuse is just using the medication other than it's prescribed. Tolerance happens, and you need an increasing dose of a medication to get the same effect. This is very common, especially in opioid management. Dependence, you can function normally on it. If not, then you might go through a withdrawal period, which is down below, which is the occurrence of uncomfortable symptoms in a physiologic state from an agent. And then diversion, once again, using that medication or legally transferring that or taking it from someone else, that's diverting that medication. Medication for opioid use disorder, MOUD. I don't really say that much. Do you guys ever? I don't know. I never term it that way, but MME, very important. So in our PDMPs, you'll get an MME. So if you're looking up a patient's drugs that they've been prescribed, their controlled substance database, you'll get MME, and that's milligram morphine equivalent. And that's how we essentially decide what a potency is compared to morphine. And we go through that a little bit more in detail. And then chronic non-cancer pain, any painful condition that can persist for greater than 3 months past the time of normal tissue healing. And our assessment. So how do we assess these patients? So in my clinic, always history is so important. I go through a very standard old carts. It's probably something from medical school you guys remember. But onset, location, duration, character, aggravating, alleviating factors, things like that. And it kind of states it here, and I think that's pretty basic for everyone in this room, but it holds true for the individual things that you're treating this patient for. And pain, a good history in pain can give you a lot of information on how to treat. So what relieves your pain, what causes the increase of pain, affects on your life. You know, how are you functioning in your church? How are you functioning in your book club? You know, how is the family? These are all affected by pain. And so, and what's the level of function? Function's huge. We want to treat these patients. We obviously want to decrease the amount of pain at any point possible, but the caveat to that is we will also want a very good improvement of your function, because without functioning, pain can be progressively worsened. So really, a lot of the things that I think myself and the other leaders on the panel do is really assess function and assess that on every visit and try to find ways to improve that function, because when that function improves, typically we see a decrease in pain. Relevant illnesses, always important. You have coexisting heart disease, thyroid issues, diabetes, all super important when we're dealing with a chronic pain patient. And when we're talking about opioids in particular, you know, how did you come to me on this dose? What have you tried in the past? What has worked? What has not worked? Why did it not work? Were you having side effects that weren't adequately managed, like constipation? I see a lot. And so it's really important to access the PDMP, the Prescription Drug Monitoring Program. The next slide, we'll go over that a little bit more. But important, if you're really concerned about a patient that's come over to you, contact the most previous prescriber or their last primary care provider or whoever was prescribing that opioid and have a discussion. Why are you leaving that clinic? Why are you coming to this clinic? Sometimes it's as easy as someone's retiring, great. Other times there's been issues, maybe concerns with the use of that medication. So very important. I have great relationships with the people in my community so that we can reach out, have my cell phone number, and have those discussions. And then determine whether the patient's opioid tolerant. Most people, after 5 to 7 days on being on a consistent opioid, will develop some sort of tolerance. So that kind of qualifier there, it's going to be prominent in the patients that you see that are already on opioids, and something that you need to address if you're planning on going through a taper or a transition to another opioid or transition to a buprenorphine type product. And then really important in the history, what else have you tried? Have you done physical therapy, occupational therapy? Have you tried TENS, massage, acupuncture? All of these different therapies that can be super helpful in patients dealing with chronic pain. And in that is really kind of my go-to, which would be interventions. Even though there's medications that we use in these interventions, they can be extremely effective for patients. What other non-opioid strategies have you used? Have you optimized non-steroidal anti-inflammatories, Tylenol, neuropathic medications? And then barriers to previous treatments, is language a barrier? Is culture a barrier? Transportation a barrier? So all of those things in the treatment history are important when you're developing your plan. And so PDMPs, this was a newer added slide. We really want everyone to be accessing the prescription databases. It's a report on the opioid prescriptions filled by the patient. They also add in there the other controlled substances. So benzodiazepines, some of the stimulant class are in there. And important so you know who's prescribing what and how often are they getting it. On this other side, the benefits, you see a reduction in doctor shopping because you can identify this patient's gone to the ED this many times, has 6 different providers for this medication. That's kind of a red flag, or lets the hair stand up on my neck to say, okay, are we seeing a pattern here? Is this an issue? In some states, prescribers are required. So in our state, I think this next slide says Utah does share data with others. Out-of-state pharmacies are not required. I think it's an obligation. Before prescribing, there's an obligation to review under certain circumstances. So in that terminology, Robin's wife's the lawyer, but I think that would mean it's not required, but very much pushed for us to be doing this and really assessing what's going on in these prescriptions. So in Utah, so it's the Utah Controlled Substance Database, and that's the website up there. It's DOPL. And you can get someone in your clinic, an MA, a nurse, to also have access to that on your behalf and check these as patients are coming in. I'll frequently have my MA search that database, give me a little printout so I know last prescription, I can do a pill count, so on and so forth. And then the reporting, like I said, some states don't cross lines. So in Florida, where I was practicing, where I did fellowship, big problem in Florida with patients coming from the Carolinas, Georgia, coming down, getting medications in Florida, and you're checking that database, and there's nothing in there. And so these other prescribers up in Georgia, there's no communication, unfortunately. I think ultimately the goal would be kind of what the VA has, and a very centralized kind of medical charting system and documentation, but we're just not there yet. So if you're seeing patients from Wyoming or Idaho, it's very important to potentially get access to their controlled substance databases as well.
Do you have any comment about what the circumstance, under some circumstances, that's always occurring? I've just never explained that to me, so I do one on every single prescription I write.
I think that's probably best practice, to be honest.
Yeah, but what's the help?
Right. So, Robin, do you want to comment on that?
Yeah, I do it every visit.
But legally, I think the question is more legally.
Yeah, there's not, it's not well-defined. You're supposed to do it before you write your first prescription, and you're supposed to contact the prior prescriber if that happens, if somebody's on an opioid, but there's not guidance on how frequently you should do it, but I do it every visit, it helps me. I mean, it's part of care.
Is that a legal thing that you were supposed to contact the prior provider?
There was terminology in 2021,
Yeah.
I think, that made notion to say that you must contact the previous provider, or at least show that you had reached out in some form.
Does that mean if they got a Percocet prescription a year ago?
It's if they've had a prescription in the past year, I believe.
Yeah, I think that's what the terminology was.
Or maybe it wasn't last year, maybe it was the last 30 days. I do it all.
Makes it very challenging.
If somebody's had a recent prescription, I do that.
So one question, when you say that you checked it every time that you're going to write a new prescription or refill a prescription, how are you documenting that if you are?
I say, I checked Utah's Controlled Substance Database.
That's good.
Yeah, in most of our clinics, we're doing pill counts at every visit, which is, we're in pain medicine, so it's very different for others practicing. But we have higher amounts of people on opioids, so it's a way for us to be very consistent and identify even when one pill is short, so we can have the discussion about that.
Is it legal to add the printout to your record?
No, it does not go into the medical chart. That's a very good question. It's there for us to access. That qualifying statement that Dr. Ockey just said is perfect in your note, and I think you'd probably be fine with that. But I'm not a lawyer, so don't take my... But, be consistent, be checking it. It might not be every time for you, but as long as you're kind of keeping on it, especially if there's, hair sticking up on the back of your neck or red flags that you're seeing, then that would probably warrant a more consistent check of that database for you. This briefly talks about marijuana. We'll talk a little bit more about that in some later slides, but I thought the interesting part about this was there's 3 states, really, those white states there, that don't have any public access program to any sort of cannabinoid treatment. Utah, it's not legal, bless you, by the way, not legal for recreational use in Utah, but we do have, if you look at a comprehensive medical cannabis program. We're kind of that middle one in the color scheme. The states surrounding us are pretty much adult and medical use regulated programs, so they're fairly available, so to speak, to patients to be utilizing. And I know some of my patients travel across state lines, which is not a good idea. They get their medications or their cannabinoid from Nevada, and I always counsel against that, but that's just the nature of where we're at now.
So will you prescribe if you know they're getting marijuana, will you still continue to prescribe opioids? So what's your think about that?
So in my clinic, I don't. We have some providers within Intermountain that will utilize marijuana and cannabinoids for treatment and co-prescribe. The idea of those practices, benzos are a whole nother, some people will not co-prescribe. I am one of those people, just the nature of my clinic, but we see it a lot. So I think back to the marijuana, the idea of utilizing a cannabinoid in therapy would be to taper off of the opioid medication. It's used in conjunction to transition. Most providers that I've spoken with that are co-prescribing are using it in that way to try to get off or lower the dose. But like I said, we'll talk a little bit more about cannabinoids because we know that there's some interaction between the cytochrome oxidases that may or may not affect how we metabolize opioids. This one is just prescribing limits, basically saying that a physician, PA, advanced practice provider, you all need education, and that's one of those components that you're here today for, because I believe you meet all of those, that 4 hours of education this year by attending this course. So there was a new statement. Robin, do you want to talk a little bit about, I don't know if it's in your slides. but buprenorphine
Yeah,
and, okay. So that'll be a little subset of the new requirements for that.
I thought they just increased it to 8 hours.
Did they?
But that's not for buprenorphine. That's for DEA, to be able to
Yeah.
prescribe any controlled substance.
Yeah.
And then they've gotten rid of the waiver or the amount of training that you have to do.
Right.
It's just part of your DEA, you're getting your DEA license, so.
Okay, and then to transition back to that patient assessment, obtain a complete social and psychological history. As we said before, mental health illnesses that are not well managed can directly impact how we experience pain, depression, anxiety in particular. So a really good psychological history is important. And in all of our practices, we integrate psychology with a lot of our chronic pain management. We have dedicated pain psychologists, and there are those out in the community that also focus in this area that can be extremely helpful for patients suffering from any chronic pain state. And then a physical exam. Obviously, you're gonna check someone with low back pain. You're gonna go through a low back pain exam. You're gonna make sure that they don't have radicular type symptoms, weakness, bowel or bladder incontinence, those type of things. Super important. And the same is true for a diabetic peripheral neuropathy. You're gonna go through a good sensory exam. You're gonna try to figure out what level of disability they have from their neuropathic pain state. Vital signs, neuro exam, musculoskeletal exam, pretty straightforward. The pain assessment, so we use a couple of different tools in our bag that can help us track function, track pain states. The BPI or the 5 A's are good pain assessment tools. In my clinic, I use the Promise 10 for our global mental health and also physical health state. And I try to track that in low back pain, the Oswestry Disability Index. For some people on this assessment in patients unable to self-report, so our dementia-type patients, our patients that aren't able to communicate their pain to us, there's different assessments. I think the PAIN AD is a pain assessment in advanced dementia. So these are all tools that you can use to help you kind of quantify, in a sense, pain and also what their progression is, and if the therapies that you're currently utilizing are helping decrease some of those numbers in some states. Really important. So when a patient comes in, you do that initial assessment. You say diagnose lumbar radiculopathy, and you start that treatment. You don't just stop there, right? You're gonna follow them. You're gonna use those tools to track them, and you're gonna do repeat assessments. You really need to stay on this because that lumbar radiculopathy could turn into a myelopathy, and they could have weakness, and you really need to be on that to send them to the right people to care for them. So you're constantly reassessing. You're routinely checking that PDMP if you're prescribing opioids, and you're willing to engage with that patient to discuss other opportunities of care. So alternative medicine is huge. Things that they may not have tried in the past, even as simple as a TENS unit, can be super helpful for some patients. So really kind of getting that history is the hardest part, but then you can look around and see what other resources you have to address their pain, usually focused on increasing that function and bettering their function. And then chapter 4, creating the pain plan. That's the end of my segment. Do you guys have any questions about what I spoke about? Over here. No notes for the. I don't know. Do they get the? Thank you.
This may be covered later, but
Yeah.
For patients that are on chronic narcotics that we're prescribing, what's the minimum frequency we're required to see?
I believe every 3 months. But if they're on a higher dose, dose matters. And I think Robin will talk to you a little bit more about that. But the higher the dose, it's not a linear relationship with that dosing. It's an exponential increase in risk versus dose. So,
Does telehealth count as a visit, or does it have to be in person?
yeah.
That's why I'm trying to do away with that, with controlled substances, that's what we're pushing for. Stimulant, benzos, narcotics.
Yeah, so we might see some changes there, but currently 3 months for your prescriptions. Okay.
There's a whole bunch of new thoughts on that.
Yeah.
And we just did a massive comment on, so it's nothing set in stone at this point. But I did find the answer to that question.
Did you?
About contacting other providers. So the law became effective on the 4th of May, 2022. It's Utah Code 58-37-6. And it basically says, and I'm just kind of looking at my notes here from when I looked at it before, a practitioner who issues a high-risk prescription must verify in the PDMP that the patient does not have a high-risk prescription from a different practitioner that is currently active. And then the Utah law defines what a high-risk prescription is. And a high-risk prescription is a prescription for an opioid or a benzodiazepine that is written to continue for longer than 30 consecutive days. So if that happens and it's currently active, you're supposed to talk. And that generates a whole bunch of other questions, but that's what the law states, and it became into effect on the 4th of May, 2022.
So to clarify, if a patient goes to ER with their kidney stone and gets 5 days.
This is probably just for that.
They get a
It doesn't click
prescription,
through that.
or they come see
Right.
me 2 days later.
Yeah.
I wasn't not you. The legislature wants me to call the ER doc who isn't at the hospital.
That's not the way I interpret the law. The way that it's written is it's a prescription for an opioid or a benzodiazepine that is written to continue for longer than 30 consecutive days.
So they would have had to see someone else who's got
So,
months worth, and then they're seeing me, and now I'm taking over.
yes.
Yeah, it's usually more of like a transition of care, like surgical and ER, as we just see. They're usually not, I hope they're not running a 30-day prescription for the ER. We don't see those as much, but yeah, transitions of care is where it gets to be a big issue. Yeah, great question.
Just thanks. Yeah, let's just see. I'm just having trouble clicking through. I'll just check really fast. Am I hitting the right button this one here, correct? Maybe battery. Okay. Okay. All right. Thanks. Not to have a delay here. Yeah, I can do that too. That's but it's just not coming up on this. No, it's okay. So while that's going, oh, great job. Yeah. It's not okay. Let me just see. Is it?
The clip-on mic
No.
doesn't actually broadcast into the room, only the podium mic does. Clip-on mic is only for
For
the
the-
recording
oh,
of
gotcha.
society.
And while that's getting worked on, I'll just say hi to everybody. I'm Josh Minori. I work with all these guys with Intermountain up at Heber in Park City, and John did a wonderful job of introducing all of us, so you know a lot about me already. But I do have a little background with PM&R, and I was an athletic trainer before, and I did a little bit of research before I started residency in orthopedics. So I do have a little bit of extra interest, not just in spine, but also kind of peripheral stuff in orthopedics and sports medicine a little bit. Yeah,
These
definitely.
slides are still open, that's the
Oh.
problem.
Josh, you're open to skiing and fly fishing questions
Yeah,
as
yeah,
well?
those things as well.
As well as Dr. Romankowski.
Not very good at them, but and
This is your set.
I'm starting off with chapter 4, which is this one right here, number 42. Thank you.
They're all
Sorry.
in one presentation, though? Yeah.
Yeah, it'll look just like this. It'll look just like that. Same.
Okay, so we're back to the beginning then? Okay. Let me,
Sorry,
yeah, no, you're
chapter
good.
4?
Yeah, chapter 4. Is there a way to go right to that on the
Oh,
computer here?
yeah.
I can click, it's fine.
Yeah,
I've
no problem.
Gotta
Should be around
get
like
my
slides 45
thumb
or 50.
my thumb work out today.
He should be around 45 or 50. It'll have the same numbers, same everything in there, so.
in, I don't know what they.
I don't think the
are.
PowerPoint slides are in the app, but,
Thank you.
yeah.
One more before that there. That's it, perfect.
You got the boring
Sorry.
reading then, huh?
Yeah.
Just
I'm
make sure
sorry,
we keep
that's not fun to read, so.
That's it.
There you go, sorry about that.
There it
Sure,
is.
There was multiple versions of
No.
PowerPoint open for some reason.
Okay, that's maybe why it skipped around.
You just have to go into that. So there's like all the pictures of your app. Either any picture, if you tap on that and go in, it will have the slides. They also have the slides. You just can't take it from that picture. You have access.
Thank you.
That's why. I'm just going to leave it right there. All right. Well, I'm going to get started here. I'm doing the next chapter, which is chapter 4. We're creating the pain treatment plan. And just a caveat before we get started, a lot of the stuff I will talk about does kind of overlap. You've heard it before, but that's not necessarily a bad thing to hear something more than once. Just some learning objectives for this. We really want to talk about applying assessment results, really to create an individualized treatment plan that really harps on it. We've all been talking about this, but functional goals, very important. We're going to identify evidence-based non-pharmacologic options and non-opioid options. We want to align a treatment approach to a specific type of pain if we can. That's not always possible, but we need to be thinking about that. We want to correlate precautions and considerations for opioid use with special populations, so there'll be a section about that. And then we're going to identify some common adverse events and drug interactions with opioids. We'll identify characteristics that can influence the choice of a specific opioid. And then we're going to demonstrate the ability to document patient care using informed consent and the patient-provider agreement as required for pain patients on opioids. So let's get started. And we're working, we're going good. So with this, how is pain managed? I mean, there's a lot of different options. Pain can be modulated anywhere along the ascending or descending pathways, which Dr. Romankowski went into detail before. In some cases, if you decipher kind of where most of the pain is coming from, you can sometimes directly impact that pain with little medication. So you really want to be thinking about how is the pain transmitted through the body and determine in partnership with your patient how best to manage that pain if you can, but it's not easy all the time at all. Chronic pain must be managed. It's not necessarily resolved. So that's a really important thing to talk with our patients. I think we can all do better a lot of the times with taking this approach to set really realistic expectations right from the start. Okay, so patients really understand kind of what our goals are and our treatment and our expectations. I often say, you know, we don't really hit a lot of home runs that time, but you can still have a pretty good ball team with a bunch of singles. So it's really important there. And then, you know, you want to talk to them about their goals and expectations and focus really on improving their function, not we're going to completely get rid of your pain, so, which I know we all do. Let's go to the next one here. So these are really components of a multimodal treatment plan. Really the idea is to establish the cause and type of pain and kind of first initiate non-pharmacologic or non-opioid therapies first, which we all do. And then you want to regularly reassess all the time because pain changes all the time, very quickly. And then we want a comprehensive plan that should be developed and customized to the needs of the individual. It's not a kind of cookie cutter, one fit all when it comes to pain. The plan should include goals of treatment, the types of therapies planned, and expectations or explanations of the patient and the healthcare team role and responsibilities in that role. Really the goal, again, expected outcomes can be pain reduction, that we always want that. But really, we want to talk about improvement in function outcomes that are impaired by the pain that the patient is having and really identify those and really how that impacts their quality of life. That's the most important thing. And oftentimes, as this slide indicates, a multimodal plan that includes non-pharmacological and pharmacological sometimes approaches is often best. Overall treatment approach and plan should be well documented. And then we want to place advocacy, as we've all talked on, you know, advocacy for the patient, empathy. We want to be collaborative, compassionate, effective communication is very important. And then evidence-based practices when we, you know, are also important there. And the point is really to keep ourselves, our patients, and the community safe with this. So really pain manage, I do like this upcoming slide here. I'm just going to put it all up at once here and just click right through and not click past it. There we go. It's kind of our goals and treatment options. This diagram's, again, kind of a detailed multimodal approach to impact kind of the pain continuum, which implies successful, useful tools and interventions from really all four categories. And, cultivate well-being, quality of life, restore function, and really the middle two, self-care and provider care. So I always talk about passive and active treatments, right? Coming in every, if they want to come in every 3 months because they think they need that epidural, that's passive treatment. But what about the stuff in between with updating your home exercise program, a frequent check with a physical therapist? Are we doing those active treatments, participating as well? Because how to maximize these passive treatments will not happen without an active approach as well. So I try to really harp on that. Even when, if luckily, sometimes they come in after an injection, they're feeling great, now's not the time to be complacent. Now's the time to maximize that passive treatment. Okay, and really get back into therapy if it's been a while. The ball's in your court at this time. You can sit on the bench with it, or you can go try to hit that 3. Okay. And so evidence-based non-pharmacological treatments, what's appropriate for your patient. This is just a long list, and regardless of the pain type, these approaches should really always be considered. Non-pharmacologic approaches have been found to be effective alone, but more importantly, part of that comprehensive plan you develop, particularly for kind of chronic pain and musculoskeletal pain. Some may be more applicable than others. Options we've listed here are all worthy of consideration, and there is evidence to support all of these. So, really the cognitive behavioral therapy or acceptance commitment therapy, and then we have the OMT for people, it's the osteopathic manipulative therapy, just to define some of those if needed. So we're going to just bring all this one up as well. So with this, this slide here, we're looking at really pharmacological treatments. And I just want to make you aware when you look at this that the medications listed here are in alphabetical order. It does not imply preference or order in which they should be used. And this is a theme throughout the rest of the slides, so please keep that in mind. The one group in here that I'll start talking about is the nociplastic pain. And Dr. Romankowski spoke in detail about this. But it's really important, and this is really arises from altered nociception despite no clear evidence of actual kind of or threatening tissue damage or evidence of disease. And it's multifocal pain. It's widespread. It really augments the central nervous system, pain and sensory processing, and you have altered pain modulating. So this amplifies pain signaling. It's an expansion of pain receptors, and you have a decrease in the descending modulation. So it's a really important aspect of these three to be aware of. There's also another term that's a little outdated. It's psychogenic pain, but it's kind of outside of the scope of this practice, so we'll kind of leave that there. Nociplastic pain, at the bottom here, very important point, should not really be treated with opioids. One example, fibromyalgia, right? These people have reduced mu receptors availability within the region of the brain that normally processes and dampens pain signals. So oftentimes opioids is not really a great treatment for them. And then nociceptive, we know that, inflammatory type pain. Think about things as simple as topical kind of anti-inflammatories. We have some compounding pharmacies around here that I've had really good success with, low-hanging fruit. There are still risks associated with those, and you just want to also be careful with payment on some of those places. They vary so much throughout. And then neuropathic pain, which we all know about here, things like antidepressants or SNRIs, duloxetine, and then neural blockades. So a lot of the things we do with interventional strategies can be really important. And it's kind of interesting, just this week I got a call on my way home from emergency room doctor that I know very well, and he had a patient show up who had plastic surgery and was having so much more increased burning pain and was not able to kind of get a hold of the physician, so showed up to the emergency room. And I think a lot of the times the knee jerk is, let's give them an opioid to break this cycle. And it was basically along the occipital ridge here, which we know there's a lot of important things and structures back there that can create pain. So we discussed some options, of course, ways to do non-opioid medication management. And then, we talked and he brought up about doing an injection or try to do some adhesion lysis with a little long-acting anesthetic like bupivacaine. Relatively safe in that area, especially in emergency room physicians' hands. I mean, they're used to putting a needle anywhere in really strange situations. And I got a call back later on and said that patient broke their pain. they had about over a 75% reduction of that acute pain, which would have initially been treated with an opioid. So it's kind of nice to think about some of these alternative approaches here. So this slide, again, is another one that we saw earlier here. This complements some of the points, again, we made earlier about the nature of peripherally mediated pain. And, you know, if the pain, we try to lump these if we can, but the body doesn't work that way, right? So peripherally mediated pain, we say, treat it this way. Centrally, treat it that way. But, of course, the central nervous system is always involved. But if you can get somebody after a recent surgery or a peripheral injury or an insult, sometimes initiation of just some anti-inflammatory medication, non-opioid options may be really effective for that person. Okay, so that's flashing at the bottom there. That's just part of the animation. But this slide here, before prescribing, you know, we should take all these characteristics into consideration. So most of these apply to any drug, but the ones toward the bottom are a little bit more specific to opioids. And the website at the bottom here really has compiled prescribing information for all opioids. So it's a really nice website to visit and to refer to in the future if you need it. This is just a new one added this year here that we all know with the CDC update guideline. We're not going to get into stuff in detail here. It's just I want to highlight a few points where some changes have been made. One, in the scope. So they've really included, you know, adults 18 years of above, outpatient with pain, looking at cancer-related pain, palliative care, end-of-life care. And they expanded it really to address more acute and subacute pain as well. They've also included in this newer evidence. So they did look at systemic reviews showing non-opioid therapies to be at least as effective as opioids in many cases of acute pains, you know, headaches, back pain, neck pain. But at the same time, they also cite usefulness of opioid therapy for moderate or severe acute pain based on clinical assessment and judgment. The other part of this is patient-centered decision-making, which we all do, but shared decision-making is a crucial concept of the new guidelines, and clinical judgment, right? As with any clinical guideline, we should use them as a means to apply evidence into our patient interaction, our patient discussions, and form our clinical decision-making, not as a set of finite rules. And this is really part of avoiding misapplication that might have happened with 2016, where there's believed to be some inaccurate or inflexible applications of those guidelines that could have contributed to some patient harm. So considering an opioid only when? You know, this information up here is in line with our information that we're providing is in line with some of these CDC guidelines. We should consider all pain management options and prescribe opioids only when non-opioid options are inadequate or when the benefit of using an opioid is expected to outweigh the risk. So really kind of determining and explaining it as a therapeutic trial. You know, you're building the expectation and understanding that this is kind of a trial or an experiment where we're going to try the medication, and if it doesn't work, we're going to stop it. And more importantly, define what works, right? We must determine that person's goals. And we're using this medication to achieve what? Functional gains, quality of life, improved activities of daily living. All of these are specific to each person and not just reduce your pain score, right? And I often say sometimes it's hard with pain, but you know, if a patient would go to their doctor and their blood pressure was not being managed consistently on a medication, would that person say, yeah, I'm okay with just keep giving it to me? But that does happen with opioids a lot, and it just shows the complexity of it. But I think it's kind of a good example. Sometimes I get the light bulb to go off a little bit with people. But so here we talk about assessment tools. We're going to kind of switch gears a little bit. They've lumped these into tools considered for opioid therapy and then tools for substance disorder. And this really just talks about some commonly used tools to assess the risk of misuse. But the big point is there's no one screening instrument that can reliably predict those patients not suitable for opioid therapy. Presently, kind of a combination of strategies is recommended to stratify risk and identify and understand aberrant drug behavior and to tailor treatment accordingly and not to undermine your clinical interaction with that patient either, okay? All patients being considered really for opioid trial, we should be checking the prescription drug monitoring program and use kind of maybe a first selection from the list. Anybody with substance use disorder or suspected problem, we may want to consider more than one and definitely one from the second area here. And then chronic pain patients, you know, that we're thinking longer-term therapy, we also want to always have that urine drug screen as well. And then the next slide kind of just really looks at the ORT here. This is an opioid risk tool. It's a 9-question measure to classify a patient kind of as high or low and risk for misusing opioids prescribed for pain. And over on the right there, substance use disorder history does not prohibit treatment of opioids, but may require additional monitoring and expert consultation. So it's a really important point. And there was a study in 2009, I think, looking at a pain management center of 48 patients where they tried to identify the ability to predict aberrancies over use of medications or just drug use. And they looked at different, basically different tools and checking the sensitivity. And the sensitivity increased exponentially with the addition of a clinical interview. So it's not just here's the tool, use it by itself, but the clinical interview is very important for really this risk assessment. And that's something that our pain psychologist that we use harps on all the time. So opioid side effects and adverse events, I know we all know a lot of these. Kind of the most common one, opioid use constipation. These medications carry a lot of risk, not present with most non-opioid medications. Specifically, the risk of misuse, addiction, which then can lead to respiratory depression, overdose, and death. Please note that the items up here were just the side effects are on the left, obviously, and adverse events on the right. And it is our responsibility to be knowledgeable about how to kind of weigh these risks before we prescribe and how to kind of properly manage these risks in patients who are getting opioids. The big one for me, and a lot of people, everybody, is the next here. So opioid-induced respiratory depression. Most likely, I just want to kind of get you on the left side here first. Really, this is the number one most life-threatening situation that we have here. And we want to use this information to educate our patients. So elderly population, we look for other depression medications such as benzos. And this big one, patients who are opioid naive or have just had a dose increase, those are the 2 times that they're most susceptible. And it's not also just, hey, the doctor increased my dose. But some patients get a very vague dose, 1 pill every 4 to 6 hours or 1 to 2 pills. And when you really talk to them, how are you using this medication? I have some people tell me, oh, I go 3 days without anything, and then it gets bad, and I take 3 of them. And I really try to stop there and say, hey, you're at risk here because you're kind of escalating your own dose, not just the doctor doing it, right? So that's one point that I like to try to make if kind of pick up on that there. And then, reiterate, swallow, tablets, capsules, and we want to co-prescribe naloxone. So drug interactions as well, 4 categories here. We have the other CNS depressants. We have skeletal muscle relaxers, right? We all think, oh, muscle relaxer, patient muscle relaxer. There's only one that works really on the muscle spindles, and that's dantrolene. The rest are essentially sedating. So you have to really, that's another big aha moment with patients. Oh, I just thought it was a muscle relaxer. But most of them know that when they get fatigue on them as well. But partial agonist opioids, so really in acute situations, patients on partial agonist or full agonist may be used with patients on partial agonist. There is literature to support continuing of partial agonists in the peri, and postoperative state with the addition of a full agonist to treat that acute pain. And maybe the partial agonist is really to maintain their baseline pain. So the next slide here, this talks a little bit about pharmacokinetics, which we know refers just the movement of drugs through the body, and then pharmacodynamics, the body's biological ability to respond to that drug. So just to highlight a few things here, opioids used with monoamine oxidase inhibitors, you have to be aware of serotonin syndrome, and tramadol is one of those. Methadone, we always think about heart, QTC. And then some long-acting and short-acting products can cause a dose dump when exposed to alcohol. So just a few little points there. This slide kind of reiterates the importance of knowing the product's specific information before you prescribe it. Consider the effect of other medications the patient might be on. And just also another thing, to be aware that pharmacogenomics now, it may be used to predict how an individual patient will respond. It is nationally available, but the payment with insurers, there's a lot of ongoing issues with that as well. Just wanted to make that point there. Oops, sorry, back. So just some special considerations if you're using transdermal, transmucosal. We don't want to cut, chew, swallow them. John mentioned before temperature changes, so patients being in hot tubs or sauna, you really got to make sure they're aware of that. Okay, and then we're going to switch right now into just some special populations here to consider opioid use in. So older population, we talked a little bit here. Complexity of managing care in older patients, really with persistent pain, I think calls for a kind of a multidisciplinary approach. We have to just be aware they have, medical problems can increase the risk of opioid-related adverse events. Respiratory depression is more likely. If someone's cachectic or debilitated patients, they may have altered pharmacokinetics, kinetics, poor fat stores, muscle wasting, altered clearance. This all can affect the metabolites in the body and the dose. They're more likely to develop constipation too, so make sure we initiate a bowel regimen there. Women with childbearing, it's kind of important to know the reproductive plans, contraceptive use, pregnancy intent status, breastfeeding plans with our patients. The American College of Obstetrics and Gynecology does recommend universal drug screening for substance use as a part of the care and should be done at the first prenatal visit. Getting trigger happy here. Managing patients in pregnant women is challenging and affects both mother and fetus. John mentioned before too with the neonatal abstinence syndrome, hypoxic ischemic brain injury, death, prolonged QT syndrome. And then opioid withdrawal can be expected in up to and over half of dependent mothers. So children, that's a tough one here. The safety of most opioids and their efficacy in this population below 18 hasn't really been well established yet. Most of these agents are really not indicated. Some non-clinical studies kind of examining opioids in children really focused on safe use more in an inpatient setting than kind of an outpatient setting. The indications for chronic use are primarily life-threatening conditions. Relatively few pediatric patients with chronic pain due to non-life-threatening conditions should receive long-term opioids. And then sleep disorders. We really don't want to consider an opioid as a sleep aid medication. We want to be very cautious with patients with obstructive sleep apnea. About 2/3 of patients who suffer from chronic pain also report kind of poor, non-refreshing sleep. I know that's always a big complaint every time. But the problem is pain and sleep, the opioids can fragment the sleep or kind of break up the sleep-like cycle. So you may be doing them a disservice, actually, with the use of the opioid there. Going back here. So, and some other ones I wanted to kind of talk about is really with dementia and other impaired cognition. We want to do a good evaluation, but just have in the back of your mind, it may not be super reliable. Pain can sometimes you want to be kind of anticipating it. It might, come up as a behavioral change or agitation. So really be aware of that, especially when you're talking to somebody and part of your physical exam. And then in obesity to another population here, with this, we always think you'll lose weight, you'll have less pain, it'll take the mechanical stress off your joints. But there are increased levels of interleukin-6, which is a cytokine, a pro-inflammatory cytokine. And it is heavily found in adipose tissue. So if you can kind of get some of that, that's another point that I like to say, that we're trying to decrease your body's inflammatory state as well, so that maybe this injury that you have may not create this significant pain flare, acute inflammation that could become a chronic too. And then always looking for renal and hepatic impairment. So those can always be changing without really seeing it clinically. And then also serotonin syndrome, which we talked about before. The CDC does recommend avoiding, like we all know, prescribing benzos concurrently with opioids whenever possible. More than 30% of overdose involving opioids does involve benzodiazepines as well. And then the end-of-life population, really getting involved with hospice and palliative care medicine should be considered early in the process. Informed consent. I always like to highlight expectations, like I mentioned before. This is really a general consent approach to any treatment. You want to discuss alternatives, pros and cons, uncertainties, assess patients' understanding of the information, and then explore what their preference is all the time. And then risk and benefits, they're not the same for every pain medication as well. So you really want to be tailoring this discussion to the specific medication itself. This is something new here, with telemedicine, from COVID. This is a telehealth module. It's a series of 4 short videos providing advice and strategies for efficient and effective telehealth visits in someone who has pain or chronic pain. And really the goal of this is to kind of help improve our pain management telehealth visits. And there is some CME available with this as well. So just wanted to put that in there. Patient-provider agreement. These are most common components of it listed above here. It used to be called, our pain contract or our controlled drug use agreement. These should be in place before your first opioid prescription is given. And then we want to review for compliance and understanding and document regularly at visits. And I often say this is kind of, we're outlining our expectations, not just the expectations I have of a patient, but also the expectation that patient has of me, of a physician prescribing this medication, or a provider prescribing this medication. It's a two-way street with this. So the non-adherence one to it. This is always hard, and I think we all struggle with this all the time. But it isn't really advisable to kind of dismiss or fire somebody from your practice kind of as a first move. There are some ethical considerations that are important for the provider-patient relationship, and we need to have kind of an exit strategy built up or in place so that we're prepared for these situations. We do have a lot of kind of, I hate to say this word, but kind of standardizations and protocols for prescribing that we make a patient very much aware of from up front. So I think that helps a little bit. Like I said, set up your expectations so there are no secrets down the line. Yes, we do have to tweak things along the way. It's not, like I said, cookie cutter, but if you're kind of upfront and open, hey, these are our protocols, this is what we expect, this is what you should expect when this time comes, it makes that conversation a little bit easier. And I think that is it for me. So, thank you all. Any kind of questions or anything before I turn it over to Robin? Yes?
So is the use of benzos more dangerous than changing from one opioid to another?
I think, yeah, just a different. If it's on the quiz, and we'll maybe wait to see what everyone says for it then. I'll take that. And we'll keep moving here with it. But we will get back to that too. I think we all have our kind of opinions on that question. We were looking at these before, and that was one that was circled for us.
I will tell you this, that there was a study in the North Carolina literature. It was like the entire commercially insured database. It was like 10 million people. And they found that the risk of overdose death was tenfold higher in patients who were co-prescribed opioids and benzodiazepines than opioids alone. Now, just one comment that I wanted to make on some of the things that we've heard. I love that we talked about how opioids are not really indicated in certain conditions, and we talked about nociplastic pain, and Josh gave the example of fibromyalgia syndrome as being a condition where opioids really are not, indicated. But that being said, I think it's really important to point out that Health and Human Services came out with a statement in 2019 that, non-collaborative tapering is also a concern and can lead to increased likelihood of going to the street, increased likelihood of suicide. And I absolutely would not start somebody with fibromyalgia syndrome on an opioid. But if someone came to me and was on an opioid, I would have educational discussions, collaborative discussions. I would really want to hopefully motivate them to not be on the opioid. I'm thinking of a specific patient right now who came from out of state who was on 200 microgram fentanyl patches with that diagnosis of fibromyalgia syndrome. And it took me a few years, but ultimately we were able to transition him to buprenorphine. That's the only opioid. He was also on 2 benzos at the time. We got him completely off the benzos, but that also took time. And it was collaborative and requiring, and it didn't happen right away, and it didn't happen in the first 6 months. There was a lot of getting to know each other, him having confidence. There was a great study that was published, I think it was 2016, it might have been 2017, by Joseph Frank. And in that study, he talked about, this was in patients who were considering tapering opioids, and it included patients who were already in the process of tapering, and also patients who had successfully tapered, and it looked at what was meaningful to them, and the relationship that they had with their provider. Having someone that was supportive was extremely important in that process, and their perceptions of barriers were pretty interesting. One of the barriers was fear of withdrawal, and so having discussions about that is important. And another one of the discussions or barriers was them not feeling like there were alternative strategies for their pain that would be successful because of the things that they had tried in the past. So I think that we have to realize that it's not a one-size-fits-all, and it's really important that we take these principles and use them in the best interest of our patients. So if, at this point, if we get to, go ahead.
Just on that same vein, I understand there's some dangers to non-collaborative tapering, but let me give you another scenario. I had a patient recently who I know has chronic pain, was seeing a pain specialist who retired, could not get into another pain specialty clinic for a month, and came to see me. Now, I don't remember what his MMEs were, but they were through the roof. And me, not being somebody who prescribes a lot of opioids, not willing to do that, and yet not wanting to leave him out on a limb. In that situation, I am not going to give him the same doses that he was on. I'm not comfortable with it. Those doses would kill a horse, let alone,
Yeah, and I think that that's an opportunity also.
Sorry, if you could just repeat the gist of the question.
I'm not sure it was a question, it was more of a statement.
Yeah, it was just,
Again,
go ahead.
The same idea of being in that situation where, I am not comfortable doing the same amount of doses that somebody else has done, but need to transition them.
Yeah, I think that that's an opportunity for education and talking about risk and collaborating in a shared decision-making way with those patients. Because, I have found that patients generally make better decisions when it's collaborative and when there's shared decision-making and when they really feel educated. As an example, in my clinic, we require opioid education before we ever write the first prescription, whether or not, and it's very rare that we would start somebody on opioid. In fact, believe it or not, I can't remember, it's been years since that I have started a patient on an opioid for a chronic pain condition. But I have a lot of patients who come to me already on opioids, who are being treated with opioids, and those patients, before we write the first prescription for them, we have discussions, education discussions, where we go through risk and we talk about tapering as part of that and about collaborating in that process. So I think there are opportunities in that situation.
So my bargaining with him is collaborative.
Yeah, I think it's really important that it be a bi-directional type discussion that's there, not a mandate that is kind of imposed. Now, that doesn't mean that there aren't situations where risk is so significant that you have to be a little bit more pointed in what you're saying. So at this point, with this chapter, we're talking about managing patients on opioid analgesics. So it's assumed that risks have been discussed, that benefits have been thought about, and that the decision has been made to move on to opioid therapy. Before I just as a reminder, it's important to remember what CDC said in 2022 when they updated their guidelines, that opioids aren't first line, that non-opioid therapies are absolutely the first, should be done first. And then you should be considering both non-opioid pharmacological strategies and non-pharmacological strategies before considering an opioid, and then have a discussion about risks and benefits Make sure that the patient understands what the expected risks are before moving forward. And make sure that you establish treatment goals before you start. And make sure you have a discussion with them about how these medicines are going to be discontinued if the therapeutic trial that was discussed earlier is not successful. All right, that being said, let's talk for a minute about opioid therapy. So this statement up here, the number 2 bullet, prescribe the lowest effective dose, is so important. We know that the risk of overdose is much higher at higher doses. And I mean, that seems intuitive, but there was a time when people thought, well, if you've been on a high dose for a long time, you're physically dependent, you're physically dependent. What's the problem? But studies that were done by Amy Bonert and Kate Dunn and others have shown that dose really does matter, and that the higher the dose, the more likely there is that the person is going to have an overdose event. We should use caution at every dose. These 2 sub-bullets there are from the 2016 guidelines. They were updated in the 2022 guidelines. Basically, we don't really have these thresholds at least according to those guidelines. What we know is that there's not a lot of evidence that opioids are going to be that helpful over 50 MME per day. We know that. But there is a lot of evidence that over 50 MME a day, there is significant harms, that harms increase significantly more. And so it's not so much looking at this 90, that is that second bullet. That wasn't even mentioned in the most updated CDC guidelines. You should always have dosing instructions, including a daily maximum. I mean, somebody writes a prescription to take 1 to 2 every 4 to 6 hours as needed for pain. What does that really mean, and how much do they take? I like to put in parentheses at the end of that, no more than 3 pills in 24 hours. And then we talk about that, and when we're monitoring compliance, that's how we measure our count, because we know that we want to keep it under a certain amount from a safety standpoint. And that is discussed with the patient, and we talk about why we're making that limit, and because of the risk and the evidence that is more risky. We need to be aware that patients are different. Every patient is unique. We need to make sure before we write our first prescription that we have our medication management agreement in hand, that urine drug screening has been done, informed consent is in place. We need to co-prescribe naloxone. I think that's one of the most important things I'm going to say today. Do you know that there's evidence that just writing the prescription decreases the likelihood of overdose, even if they don't fill it? There's evidence of that. And so writing that prescription is really, really important. And there was an FDA advisory that came out, it was in July of 2020, that basically said that we should, and it's telling providers, you need to talk about the availability of naloxone with every patient on an opioid. Okay, then they give you subgroups where you need to make sure you prescribe to, but you at least need to talk about it. I will tell you, I write a prescription for naloxone for every patient where I write an opioid. And go ahead.
Well, when I'm saying we are writing prescriptions for naloxone, and they're looking at where the purpose.
Yeah,
Yeah, I've seen that too.
yeah.
He's even seeing ERs who may only write 3 or 4 tablets, still prescribing naloxone. We just had a patient in one of our clinics who was getting an OB surgery, and one of our PAs saw that they were probably need to have an opioid for that surgery. The surgeon was writing it. He gave her naloxone for it. About a year later, she got in an argument with her family, went down and took the rest of the oxycodone she had from her surgery a year before, but they had naloxone from one of our PAs, saved her life. So I think if it's 1 tablet, or even if you're on it, the pushback we get a lot is expensive. My argument is prescriptions are not expensive for me to prescribe. I should be able to put that decision in my patient's hand. 'Cause even though they may say no to me in the office, they may change their mind a couple of days later. Mm-hmm. So it's a really easy way to enable patients to just be smart with their health care. So good ER docs
And
for you. So.
Some of the pharmacies are not
Yes, yeah, because I know there's free naloxone out there and Narcan, but yeah, prescription is, I think, and smart on so many ways, like Robin's saying, so.
Yeah.
Yeah, agree, couldn't agree more.
Just to move on, but a couple more thoughts on naloxone. We should be thinking about prescribing naloxone on our patients that are at risk for overdose, even if they're not currently on an opioid. I mean, and if they're children in the home, that's a particularly important subgroup. Inadvertent exposure to a child, I mean, that could be a devastating event. Clearly, if somebody has opioid use disorder, if people are on opioids plus benzodiazepines, but like I said, those are the areas that were highlighted by FDA when that advisory came out. But the bottom line is, for me, I just write prescriptions for naloxone for everybody that I write a prescription for an opioid. I think I just accidentally hit that. Okay, yeah, so to continue, reevaluate. If you write your first prescription, you should reevaluate more frequently initially when you're trying to see how things are going, and a lot depends on the dose. There's a lot of individuality on that, but at least within the first 4 weeks, you should be seeing patients after their initial prescription. I commonly would see them after 3 or 5 days, and I do that same thing if we're doing a dosage change or if we're rotating to a different opioid. Reevaluate every 1 to 3 months depending on risk level once they're on their more stable dose. And a lot depends on their risk level and the harm-benefit ratio. Okay, so we also need to be doing good follow-up for our patients. What do we do in our follow-up? Well, we look at functional goals. You know, we've set those initially. Are they more functional because of the opioid? And we can reset those goals if we feel like we need to do that. We monitor for breakthrough pain. We try to treat breakthrough pain. That doesn't mean that breakthrough pain has to be treated with another opioid. I mean, we should look at the breakthrough pain individually and separately, and there are lots of things that can be done for pain, and that includes for breakthrough pain. We review adverse events or side effects at every single visit. You need to make sure you're looking at bowel function. Constipation is extremely common, obviously, with opioids. We know that opioids can impact the hypothalamic pituitary adrenal axis. We know that it can lead to sexual side effects, hypogonadism, decreased sexual desire, and rarely it can lead to adrenal insufficiency, so that's something we should be looking at as well. Rotation. We'll talk more in detail about opioid rotation later. We need to make sure we're regularly checking and monitoring our patients to evaluate their safety. And here's the bottom line. If we establish up front that we are treating their pain like a disease process, and we need to monitor somebody just like we would monitor somebody that has diabetes, and that this is to monitor their safety, this is because we care about them. It's not because we're trying to find something that they're doing wrong. And I think that's a critical thing. So checking the drug monitoring program, the Utah's Controlled Substance Database in the state of Utah, use urine drug screening. And again, urine drug screening can be really helpful in identifying things that are dangerous for the patient. Go ahead.
Do you do an in-house or do you send out? Because you said you don't, until you get your urine drug screen back, you won't prescribe.
Yes?
So if they're in on first visit expecting a prescription and you send out?
Yeah, so we send ours out. And we're going to talk in a little bit about what type of urine drug screening we do. But our patients are told up front we're not going to be prescribing. And our referring doctors know that we're not going to be prescribing opioids on the first visit. We do a lot of things between that first visit and the prescribing visit, which includes the opioid education that I talked about. We actually, if we're thinking about prescribing chronically, we even have a psychological assessment for a lot of reasons. And we get the urine drug screening results back, and then we consider prescribing. This isn't an acute pain issue where right now we want to give them something, but I'm talking about the chronic pain scenario. Okay, so we also should be monitoring them in each follow-up visit for the development of substance use disorder, opioid use disorder. We need to make sure that we are looking at all of the medications that they're on. What is termed here medication reconciliation. What if their primary care provider or their psychiatrist or someone else wrote a benzodiazepine between the last time and this time? I need to know that, and if I'm not asking that question, that's really, really important. And we're also looking for non-adherence to the treatment plan, not so that we can then say, aha, go away, but so that we can intervene and have good discussions with them and manage that situation. As we monitor these patients, these are the 5 A's of pain management. So we look at, is it helping their analgesia or their pain? Is it helping their function or their activities? Are there aberrant, I don't like to use that term aberrant, but it can help you remember that this is one of the 5 A's. Are there any adverse events that have occurred between the last visit and this visit, and how is their mood? Those are the things that we look at every single visit that somebody comes in for follow-up. We also are looking for substance use disorder or opioid use disorder, the 4 C's, so to speak, like loss of control, compulsive drug use, craving, continued use despite harm, are things that you should be thinking about and that the patient should be thinking about. Before we write our first prescription, we talk to our patients about the risk of developing opioid use disorder. We consider that a side effect that they need to be warned about. And so we tell them about these behaviors, loss of control, and to be monitoring. So we're looking at it, but we want them to be looking at it as well. And part of this is the 5th C, of course, is that this is a chronic problem. Okay. When do you move from extended release, from immediate release to extended release opioids? The first statement I would make about this is that there is some evidence that the risk for unintentional overdose is greater with long-acting opioids than with short-acting opioids, and that's particularly worrisome in the first few weeks. So that's point number 1. So be aware if you're switching that there is that increased likelihood. The second point I would make is when you go to long-acting opioids, in effect, you're telling the patient to take an opioid at night, right? Because it's long-acting and it's going to be at night. And we know that there are increased risks when people are sleeping. So I would think long and hard before considering going to a long-acting opioid for that reason. That doesn't mean that there's not a reason to do it. And sometimes pain is worse at night. But if it's not, and many of my patients, their pain isn't as bad at night. It's really bad during the day when they're active and all of that. So going to a long-acting opioid may not be the best choice. But these are reasons, and you can read them as well as I, of why people sometimes go to long-acting. It's a longer duration of action. You're giving multiple immediate release opioids during the day. There's end of dose failure, that sort of thing. So anyway, and again, the last one is less sleep disruption. But at the end, there are other ways to manage sleep. And if you do feel like their sleep is disrupted, be darn sure that it's because of pain and not other causes. Because to give somebody an opioid during the night, I think, is a scary thing. All right. Consideration. These are some critical things to be thinking about when you're changing from an immediate release to a long-acting opioid. There are some opioids where it's only opioid-tolerant patients that you should transition to that opioid. So long-acting forms of hydromorphone and fentanyl patches are both, if you look at the prescribing information, the patient needs to be opioid tolerant. In a little bit, I'll show you a slide about how to define opioid tolerance. We need to monitor very closely for respiratory depression. I already mentioned that the risk is greater when they're on long-acting. And then this is all individualized. And we need to make sure that if we're titrating a long-acting opioid, often there are guidelines in the prescribing information for that individual opioid, so you can look there. All right. Hyperalgesia. In that initial education that we give to our patients, we talk about hyperalgesia. In fact, I talk about hyperalgesia right after I talk about tolerance. And I say, tolerance is one reason why your opioid may lose its efficacy with time. And then right after that, I say, there's another way. Just being exposed to an opioid, and I ask the question to them, were you aware that being on an opioid chronically may worsen your pain? And the vast majority of patients say, no, I wasn't aware of that. And then we talk about opioid hyperalgesia and the likelihood that it can lead to increased sensitivity to pain. By the way, opioid hyperalgesia risk is greater when patients are on higher doses. It's also greater when patients are on opioids for longer intervals of time. So I think that that's something to point out to the patient, that dose matters. Here's another reason to keep your dose low. So not only is your risk for respiratory depression and death greater at higher doses, so is your risk for opioid-induced hyperalgesia. And this is just the description of it. You can see that. Okay, this is the definition of tolerance. It was per Food and Drug Administration. Somebody that's on this, and don't get caught up in calculating the equivalency because some of these aren't equivalent, but this is for some reason the definition that Food and Drug Administration came out of what would be an opioid tolerant patient, being on 60 milligrams of morphine or a 25 microgram fentanyl patch or 30 milligrams oxycodone a day, et cetera. Okay, so tolerance occurs when you need an increased dose to maintain that functional status. I tell my patients all the time, tolerance is more complex than that. Tolerance is complex because there's individual variability, but there's also a variability between effect and effect. So opioids have many effects, and tolerance develops at different rates for those effects. So we could be talking about tolerance to analgesia. We could be talking about tolerance to constipation. Those are two very different things. We could be talking about tolerance to nausea, which is pretty quick, right? I mean, most of the time people don't have persistent nausea. So we talk about those things. Physical dependence is different. Physical dependence is a discussion that we have with our patients all the time. And it's important when we talk about talk to them about risks of opioids to mention physical dependence. And we say, the way that you know you're physically dependent is you're going to go through withdrawal if you stop it. And I ask them, how long do you think you need to be on an opioid in order to become physically dependent on it? And that leads to a discussion about withdrawal and what that is. And it's a flu-like syndrome. And we talk about the symptoms of withdrawal that could occur. And I tell them, I don't want them to go into withdrawal. So don't abruptly stop your medications. If we're deciding to taper, let us be involved in that process. Opioid rotation, this is just basically changing from one opioid to another. There are various reasons to do that. Maybe the opioid that they're using is not effective. Maybe they become tolerant to the effects of that opioid. There's sometimes rotating to a different opioid would allow you to get better efficacy by not increasing your MME. Remember, and we'll talk about how you should dose reduce when you rotate in just a minute with a different slide. All right, next slide. Okay, so this is just talking about equianalgesic doses of opioids. There are many different calculators that you can see online. There are apps that do this. I happen to like the one from Practical Pain Management, but there are others that are just as good. And you can then calculate out what milligrams of one opioid equal in milligrams of the other. They vary significantly. This is an example of one, and you can see there that it just shows that 3 milligrams of morphine equals 2 milligrams of oxycodone if both are oral. So oral doses. In the parentheses under usual starting doses, those are the parentheses are for people with liver or kidney function issues or older patients starting at lower doses. But once again, you could get pretty high if somebody, if you look at oxycodone, taking 5 to 10 milligrams every 3 to 4 hours as a starting dose, what if they took 10 milligrams every 3 hours? So that's, 80 milligrams of oxycodone, which would be, at 120 milligram morphine equivalent. So you can get pretty high. So talking to the patients about a ceiling of how many pills they take in a day, I'd like to emphasize that once again. So there are many different subtypes of mu receptors. This may explain the individual variability from opioid to opioid and why rotating from one opioid to another might be beneficial in certain situations. It kind of explains that incomplete cross-tolerance concept. This is just talking about guidelines for opioid rotation. It's recommended that you you calculate out what the opioid would be in the new dose or the new drug, and then you cut that dose by 25 to 50%. You err on the side of 50% reduction if the person's really medically frail or they're on relatively high doses. If they don't have that, some people suggest you can go to 25%. I always go to 50%. But I see the patient back really quickly after the drop, because what if they don't I mean, there's incomplete cross tolerance, and I would like to get the dose as low as possible. And so if I see them back in a few days and I tell them this might under-medicate your pain, it's very unlikely that you would go into any withdrawal, but it may be just right for you, and there's even some chance that it could be over-medicating you because of, and I explained the concept of incomplete cross-tolerance. So I want to see you back in 2 to 3 days, and then we'll evaluate and decide together what we're going to do here. So I think that, I always err on that. I love the point here about methadone. The reduction with methadone is 75 to 90%. That's because methadone has, its metabolism is quite complex. Its MME is much harder to calculate. There was a study published in 2017 that looked at data from 2014 that showed, I think it was 22.9% of all deaths at that time from prescription opioids were due to methadone, and only about 1% of the prescriptions were. So methadone is particularly dangerous. By the way, you should never give breakthrough medication doses of methadone or of other long-acting opioids for that matter. But I would just really recommend that you stay away from methadone for chronic pain, but realize that if you do have patients that are on it, transitioning to and from methadone is complex, and I would reach out if you're not experienced in that.
So by that, do you mean 75 to 90% reduction if we're going to methadone?
Yes. Yes. In fact, this gives a little bit more information, and you should never go, even, let's say that calculates out, and opioid equivalency charts for methadone are really hard to read because as you get higher on your methadone dose, the MME gets exponentially higher. It's not linear. But the bottom line is, when you're looking at this slide, you would never start somebody on methadone by more than 30 to 40 milligrams. In fact, I would never start even close to 30 or 40 milligrams. I would start much lower than that, even if your calculations work out that way. So you don't want to start people on too much methadone. It's got a long half-life. It stays in their system. They may not die today, but it could be 2 or 3 days from now at that dose that it's a problem. And so I would just really encourage you, if you don't have experience with that drug, to not prescribe that drug. And that being said, methadone has been an amazing drug for opioid use disorder. It's saved countless lives. It's not that I'm trying to badmouth methadone. It's just, there's a lot of concerns when you're doing it for chronic pain and in situations of titration, et cetera. Yes, and depending on the corrected QT interval, I would get follow-up EKGs on a certain cadence. Yeah.
Yeah, I had attending and very experienced pain attending is down as early 80s. When I trained, we'd always call it the Coumadin of pain meds, just to let us know like it interacts with everything, you know. And he told the story about a patient that was on methadone for 20 years and was put on ciprofloxacin and a Z-Pak over the weekend, and you know he was deceased by Monday. Despite the methadone was the only thing that changed. You know, he always told that story every year. It was early on in his career that happened, and we used it a lot for our cancer pain patients in training, and we had a lot of sickle cell patients. We had HIV neuropathy patients. We were at a county hospital in Texas. We used it quite regularly, but yeah, it's highly unpredictable, especially with QTC. I would get at least annual EKGs. There's not any recommendations, and you could even do quarterly, and then people with histories of arrhythmias, I'd stay away from it, but yeah. It can be a great med in the right scenario, but very highly unpredictable, but yeah. Yeah.
Okay, so the last thing on this slide is transitioning to transdermal fentanyl. It's also somewhat complex. If you look at the charts within the prescribing information, they're meant to be unidirectional. That's really important. So transitioning to fentanyl, those charts are really helpful. Transitioning from fentanyl, you're going to overdose your patient if you use those charts, because they're conservative. You don't want to over-medicate with fentanyl. So, it's going to be very conservative that way. So be very careful and realize it's a unidirectional transition. This is just showing how to calculate MMEs. I mean, you guys, this is just, takes you back to high school, I'm sure. Just calculating out, so you got somebody that's on a oxycodone versus morphine, so 2 milligrams of oxycodone equals 3 milligrams of morphine, and they're on oxycodone, you're switching them to morphine, and they were on 30 milligrams, and then you say, okay, if 2 is to 3, then what is 30 equal to that? And so there you go. So that's just showing how to calculate out a morphine milligram equivalent dose. All right, so if you choose to give them an opioid for breakthrough pain, and I want to emphasize that that's probably not what, I mean, that would not be my first line. If I have somebody on an opioid for pain, I'm going to look at other ways to manage their breakthrough pain. But if you choose to do it, it's to keep the dose about 5 to 15% of the around-the-clock dose. Abuse deterrent medications. It's not too long ago that Food and Drug Administration made this a priority. It wasn't the Shangri-La that a lot of people really thought that it might be. The good news about them is that they do seem to, they theoretically will decrease the likelihood of somebody crushing and snorting or crushing and injecting the medication. The problem is you can still misuse them by taking a higher volume of them. So they're still easily misused. And the other problem is that they're quite expensive, and a lot of patients can't afford them because they don't have, generic options available. Urine drug screening. So I like that statement at the top. Urine drug testing is for the patient and not to the patient. It's not something done to them, but it's done something for them to keep them safe. And if you've established that up front, if your patients know every single patient that I have on an opioid, I'm going to get urine drug screening. Every single one. Because I know that 25% of all chronic pain patients, and I tell them before I write the prescription, if you look at the literature, 25% of all chronic pain patients are misusing their opioid. And I also know that up to a third of patients who are on opioids for chronic pain will develop addiction to that to the opioid. So if that's true, and there's different studies, and some studies estimate that it's lower than that, but if it's that high, I should be monitoring for that. And so I'm just like I monitor diabetes. So I make sure that they understand I'm doing this to keep you safe. And if I find something, it's not for me to point my finger and I'm going to wrap my arms around that person and really try to help them, deal with that that issue. Yeah.
You're probably familiar with the poppy seed issue.
Yeah.
A bunch of poppy seeds or a roll of poppy seeds, does that give you a positive drug urine?
Yes. So if somebody has a positive morphine on liquid chromatography or gas chromatography, if they have a positive morphine, there are 5 sources. And I know it's 1 of 5. Okay? It could be morphine. It could be codeine, because codeine breaks down to morphine. It could be heroin, because heroin, the chemical name for heroin is diacetylmorphine, and it metabolizes to monoacetylmorphine and then to morphine. And it could be poppy seeds. Poppy seeds, I mean, there are 2 natural occurring opiates, codeine and morphine, both derived from the poppy plant. So morphine is going to be there. Or it could be opium, which you can theoretically get online. But I know it's 1 of those 5. So I tell my patients, before I ever write the first prescription, that I'm going to be monitoring them, and I don't want to see morphine in their urine unless they're on morphine. So they commit to me. They promise right up front that they won't use poppy seed products, because I tell them up front, if you use that and I see morphine, that's concerning. It's concerning because of the risk of addiction on these drugs. It's concerning because I know that a third of people could become, addicted theoretically. So if that's the case, and somebody is using, I'm going to assume it's possibly heroin. So don't ever use poppy seeds, and they promise me. And I also tell them it's been over 10 years. It's probably been 15 years since I've last eaten a poppy seed product, because if I'm going to ask them to do it, I'm not going to eat it either. But I'll tell you, when I retire, I'm having that lemon poppy seed cake. But I haven't had any in 15 years. Okay. Okay, so bottom line is, on immunoassays, they're not specific, they're not sensitive, and there can be false positives and false negatives. If you look at the newest CDC guidelines, they talk about how that is still a really good idea for some patients because it's more cost effective. I haven't found that to be quite the case because often there are so many false positives and false negatives, and you send it on for confirmation, and then there's the cost of both and all of that. But and nowadays, there are some labs where you can get liquid chromatography, much cheaper, but it behooves you to check and see the cost of a lab and what lab test you can get because liquid chromatography can be quite expensive. But they're very sensitive, very specific, and you're much more accurate. And it's nice to be able to talk to your patients with confidence. So I try to use that. But there's a case to be made for the other, as I said. Detection windows. There's so many variables. I mean, metabolism, size of the patient, and all of that. And if you look at THC, for example, it says 1 to 7 days. But if you look at the Mayo Clinic website on THC, if somebody uses one single use, it's probably 3 days you're going to detect it. If it's kind of moderate use, like 4 times a week, it's about 7 days. If it's daily use, it's about 14 or 15 days. If it's multiple times per day, it's more than 30 days. So with THC, for example, it's very, very variable. Heroin, heroin has a half-life of 3 to 5 minutes, and so it's out of your system by, in a matter of, like I said earlier, it metabolizes from heroin to monoacetylmorphine to morphine, and it can be, you might not ever see heroin. Go ahead.
I don't see fentanyl on there. Is there a reason?
Oh, it's just not there. I can't remember the exact.
It's metabolized very quickly.
It is, but I don't remember the exact detection window, to be totally honest.
And it's not a way to test, so a lot of those urine tests you can't.
Yeah, I always test for fentanyl, but I do liquid chromatography. The real problem for me is that some of the newer analogs that are illicit off the street aren't going to be detected either, possibly. So I just don't know how accurate they are. It's kind of like methamphetamines. Sometimes, it's hard to know between, is it the person took Sudafed or did they do something else? And there are certain ways you can have the labs break it up if it's positive to test for it. But you have to have discussions with labs in advance and let them know what you want. Yes, you're looking at the DNL isomer and the ratio in greater than 20% versus less than 20%. Except for after 24 hours or so, it might not be there. Yeah, because 6-MAM metabolizes to morphine. So by the next day, it might not be there. So what you might see with heroin, so if somebody does heroin, I tell my patients this example when they commit to not use poppy seed products. I say, look, somebody that does eats a poppy seed muffin this morning, their urine may look exactly the same this afternoon as someone that did a bag of heroin yesterday morning. Because by this morning, you might still have 6-MAM in there, but by this evening, probably not, but you probably still have morphine. So that's why I tell them, please do not use poppy seed products.
What about the tests that are negative that you expect to be positive? I had a patient that I could see the fentanyl patch on his back, and the test was negative.
Yeah.
And I don't know what to do with that information.
Yeah, so first off, that particular example is highly unlikely. But, I've seen everything seems to happen now and then, right? But a negative test should not make you think all at once of non-compliance or diversion. Those are two things that should be coming through your mind as a possibility. But that should lead to a discussion with the patient to investigate it further when somebody has a negative test to try to figure that out. And also, sometimes you can have lab error, which in my opinion would be the most likely answer for your particular example would be lab error. And I will also say that if the situation was, if the drug screening was by immunoassay, it's going to be negative because they don't really test well for fentanyl. So it'd have to be liquid chromatography.
Do you observe the urine sample being given?
Nope.
How do you avoid fake urines?
Well, number one, we check temperature, and I think that's really important. There are adulterants that you can check, but you're right, we're going to miss some. But it's hard, especially if people are on complex, because I get liquid chromatography. Somebody comes in, it would have to have all of the stuff that they are on and none of the stuff that they aren't. So let's say they're on gabapentin, and that's a whole other discussion because we know that the FDA warning that came out in 2019 on gabapentin, that there's a higher likelihood of lung problems or respiratory depression on opioid-taking patients when they take gabapentin. We know that, but I still have some patients on that combination. So their urine would have to show, they have to show gabapentin and the drug and with the metabolites. It's unlikely, but this is not, we're not doing, it's not like we're in the military. I used to be in the military, they'd watch it hit the cup, you know? I mean, it was just the way it was. But nowadays, but I don't have somebody watching patients give a urine sample, and I don't think I ever will. Okay.
How often are you routinely doing your urine drug screening?
It depends on risk. So if you look at Utah's guideline, I think it came out in 2018, they stated that you should get it about once a year. If you look at national publications, they suggest that you base this on at least once a year, but base it on risk. And so my low-risk patients once a year, my moderate-risk patients maybe every 6 months, my high-risk patients every 3 or 4 months, my extremely high-risk patients or patients with opioid use disorder maybe monthly or even randomly in addition to that.
So are you identifying them with like COM, or opioid misuse measure, saying that there's this, that, this?
So that's one of the tools that we use. We also, you know, if you look at the most recent CDC guidelines and even the older ones from 2016, they talk about how our tools for identifying risk aren't that accurate. So it really needs to be, unfortunately, I wish it was accurate, but they can be an adjunct to other strategies. So the combination of urine drug screening, medication counts, some tools like that. We have a psychological interview intermittently. All of those things can be helpful, but your clinical judgment is also a part of it. Okay, I think that's enough on detection windows. This just shows the metabolism. A lot of it we've already talked about, but poppy seeds, going back to that, you can see codeine of morphine from poppy seeds. Morphine, 10% of that will metabolize to hydromorphone. You often don't see hydromorphone in somebody that's on morphine unless they're on higher doses of morphine. Hydrocodone, of course, breaks down to hydromorphone. Oxycodone breaks down to oxymorphone. And then we've already talked about heroin and 6-MAM and all of that. All right. Considerations for reevaluating or the opioid use. So this is basically saying, when do I taper, right? When do I consider tapering? Patient moves past the point of need. Maybe their pain's resolved, okay? Or maybe they decide that they don't want to be on the opioid because they had that discussion with you and you talked about the dose and you talked about the risks and they get it and so they want you to work on with them for tapering. Maybe they aren't reaching therapeutic goals and so you say, look, this isn't helping you. Do we really want to continue this medication? Or maybe their situation's changed. They no longer, they really need to be on that benzo according to their psychiatrist. So now being on the opioid is way riskier. Or maybe they developed a new lung problem or whatnot with new medical problems. And so the risks that you thought before were outweighed by benefits no longer are outweighed by those benefits. Misuse behaviors can be a reason for reevaluating, but misuse behaviors by themselves don't mean I'm going to taper right now. But it should generate a discussion, and it may lead to tapering, depending on the situation. There are many different tools because we talked about the fact that somebody can have an increased likelihood of opioid use disorder on opioids. So there are different questionnaires that can be used. I don't use most of these. The psychologists that I work with use some of these. We've used the CALM probably most often, but there are different measures that we can use. Okay, so approaches to support this discontinuation decision. So number one, it should be taper. If you're going to discontinue, you should taper. It should not be abrupt discontinuation. If you suspect opioid use disorder, you should probably consider medications for opioid use disorder rather than just tapering off of the opioid and referral to somebody that has expertise in that arena. Consider rotation to buprenorphine. There are lots of reasons to consider rotation to buprenorphine. We don't have enough time to talk about all of them, but there is certainly a much lower likelihood of overdose on buprenorphine. And buprenorphine, if they're going to be on an opioid, buprenorphine is a good choice. There's others, besides overdose risk, there are other potential benefits besides lowering the risk for overdose. There's theoretically, in some publications, a decreased likelihood of hyperalgesia. There's some publications that suggest that there's a decreased amount of tolerance that might occur with buprenorphine. There have been publications recently. FDA put out an advisory, I think it was in January of 2022, about the dental problems that can occur in conjunction with oral formulations of buprenorphine, and we need to be aware of that. But there are also recommendations of things to do to try to mitigate that. So those are all discussions that you can have with your patients. A really important point here also is the speed of the taper. It says that you use you take each patient individually, but I will say the vast majority of the time, and I don't think I used enough VASTs. Almost always you go slow on your tapers. There's evidence out there that the risk of harms with tapering are much greater with faster tapers. Every week that you add lowers that risk. So I think that slower tapers are better. And patients like that too, plus they're less likely to go through withdrawal. And if they are going through withdrawal, because maybe they want to taper fast, and it's a collaborative thing, there are medications that you can use for that. And if consulting a pain specialist is an eventual, option, if you're having issues or I don't feel like I want to take care of this complex patient for this issue, I want to just focus on their other medical problems, a pain specialist can be helpful. And I think it's important that you talk to your colleagues in your community in helping you decide which pain physician to use, because not all pain physicians are created equal. But I think that consultation referral is a really optimal choice in some situations. Document. My last thought on this section. Document what you do and what your thought process is, as it says. Any other questions before we move on? All right. Oops. Ooh, that was close. Back on.
Okay, I'm back last time here. So in Chapter 6, really we're going to try to identify effective communication strategies for educating patients, caregivers about, we're going to look at safe use, storage, disposal of opioids, and discuss naloxone here with this. And again, we always use this word, but education is so critical here. So we really want to take time to be clear how you instruct your patients and just instructions about taking opioids as prescribed. We often say we want them to adhere to a dose regimen. Now, that is something I talk about all the time, but I also want to know communication if they're having issues with that before they then determine themselves, I'm going to change my dose. So if we have increased pain, they know I want them to make my office aware of it as soon as possible so that we can have that open discussion. But otherwise, we would stay on the medication dose that we had talked about and agreed on at the previous visit there, but that can change. We also want to explain to patients that you should use the least amount of medication obviously possible to reach that therapeutic benefit and kind of for the shortest amount of time, depending on what type of situation we're trying to treat here. We want to kind of always, like Robin said, document what has been taught to your patients and also really have discussions with other people that in the home that might be helping to manage these medications as well. So again, with education, this is a handout from the FDA that you can kind of provide to patients as part of the discussion. When we go over our MMAs, we actually have little sections of further education material that we give to them. I like that because in the office, not everything sticks. So if they have something they can take home and look at whenever, a lazy day on a weekend, if they want to open up a pamphlet that we give them, it can help stem a lot of questions on follow-up visits that might not have ever come up. So I often get a lot of stuff, further education from that at-home information. So I think that's really important to have. And then again, we've talked about this a lot. So we really want to stress this importance of anticipatory guidance for patients and caregivers. We want to proactively educate on all of these kind of side effects and adverse events. Like Robin had mentioned with opioid-induced hyperalgesia, I think that's a time of education where a lot of patients aren't aware of that. Most patients are aware of some of these other side effects. They come in already knowledgeable about that, but if you can have an understanding of all of them, you might be able to present some things that this wasn't on their radar coming in. And then, okay, the bottom picture there, we've seen that a bunch, just kind of drives home the point for a patient that these receptors do exist everywhere in the body, which is why you have so many different side effects that can happen. So counseling again, we talk about warning signs for safe administration, and then warning signs or safety concerns. So never break or crush or chew. If a patient can't swallow these medications, you can refer to package inserts a lot of the times for information on potential alternative methods of delivery, which can be really helpful. And then kind of what to look out for. It's really important, nodding off, taking more than prescribed. Just make sure everybody in the home is aware of these things, not just the patient themselves. Again, we're back again to opioid-induced respiratory depression. And if you focus on the bottom part of this here, the greatest risk for this is when co-prescribed with benzodiazepines there. So also most likely to occur, we talked about opioid naive or these quick, abrupt jumps in dose, either planned through the prescription or self-administrated because not much direction was given with the initial prescription, and a patient is then determining how they would like to take it there. So a lot of times too, sedation is big. So I always say, hey, if they're sleepy or nodding off, that's something to really be concerned about. Don't just ignore that. Don't jump right on it, but that's often the first thing that then leads to respiratory depression. Robin had mentioned this always a bunch in some of his lectures, and I picked it up and I talk about it, is patients always, one thing that's been hard in the past to talk to a patient about is they say, hey, I've been on this medication for 15 years, 20 years. I take the same dose at 8 a.m. and the same dose at 8 p.m. You're telling me I'm at risk for a problem. Well, I say, yes, without organ systems like the liver or kidney, these medications don't do anything. So they're processed. You could have an insult to your kidney or your liver and not really know it's happening and then be susceptible for an elevated level of medication and have a fatal event. We've all kind of been in those situations that we've seen that. So this is a big one too here, signs of accidental opioid poisoning. We want to seek medical treatment if it happens or overdose occurs. Whether to call 911 or give naloxone is dependent on the situation, but giving naloxone should not mean we don't need to call 911. It always happens, always. From 2005 to 2018, 14-year period, 47% of all fatal poisonings in toddlers involved opioids. So naloxone itself, we do know, a lot of us know here, that it's opioid antagonist. It's meant to kind of reverse the opioid-induced respiratory depression, allowing for someone who's overdosed to regain consciousness and breathe normally, but it will precipitate the reversal of the analgesic, and withdrawal symptoms can happen. So that's something else to educate your patients on as well, to be expected. It does have a shelf life of about 2 years. And then consider each patient's access to this. So everybody's a little bit different how they can access this medication here. Institutions, some like ours, they do have little pop-ups that happen in our electronic medical record to kind of flag it every time, just as a reminder, which I think is very helpful. And naloxone itself doesn't have any abuse potential. There are different options, that can come as an auto-injector, intramuscular injection, or nasal spray. There are some videos online on YouTube about how to administrate all of these, so that can be helpful for patients to just jump on and see a video. And then regulations is in May of 2017 with kind of criminal immunity. It does protect us as professionals from liability for prescribing this or dispensing, and also lay people for administering it. It is available, Robin had mentioned before, to third-party people such as family members or bystanders. And then there is a standing order from a physician. It can be carried out by other healthcare providers when predetermined conditions have been met or documented.
And it's available now without prescription, is that correct?
For third-party, so like for third-party people that want to have it, or innocent bystanders if you're a layperson,
Go to the pharmacy
and can get it.
It's over the counter now.
Mm-hmm.
What's the
Yep.
cost for intranasal?
It changes quite a bit. Do you know the most recent one?
It was around
I thought it.
in the hundred something range.
Mhm.
It's
Yeah.
really ridiculous, the cost of naloxone. And one of my worries, I love the idea of over-the-counter, but I worry that it's going to decrease availability in other ways. I think in the scheme of things, it's going to be a good thing, but I worry that it's going to decrease, especially if it's so expensive that they put it behind the counter of the pharmacist, so that they have to ask for the over-the-counter medication, which might take away or might eliminate the benefit of less stigma, which is hopefully something that'll happen. It is expensive, but I tell my patients all the time, I don't want you to not have naloxone because of cost. So if you can't afford over the nasal spray, there are pre-filled syringes options. In most pharmacies, you can get that for much cheaper, as low as $25. There are some places where you can get it for free. There's the Utah Naloxone website. They will talk about that. I know that in Salt Lake County and Utah County, the county libraries will allow people to go in and just ask for it, and they'll give them a pre-filled syringe, and it's free. Yeah, along with your book. So there are places where you can get it for free, but that's not the nasal spray, which I wish they could have, and I guess that's good.
GoodRx has it for $52 nasal spray.
GoodRx helps too.
Yeah, and that, someone walking around with serious, allergic reactions without an EpiPen, sometimes I make that call, you wouldn't be out without that. This is, it's a serious thing, So safe opioid storage and disposal, we want to teach our patients and caregivers about safe storage, disposal, protect the patient and family members and people in the house. So this was something put out by a partnership of Drug-Free Kids, where we monitor, secure, and dispose. And some other little tidbits I picked up, Mathew mentioned this before, Dr. Romankowski, about how they take the medication. Make sure where you're taking it, the environment where you're at is appropriate. Over maybe a large flat table, I have some patients that take it, they just bring out a big salad bowl and make sure they take it, so that if they drop something, elderly patients, not good dexterity, it's easy to drop it. It's on the floor, it looks like a piece of candy. And then also sometimes I'll recommend that they also have a separate pill bottle that they can get from the pharmacist that's labeled, that they can keep their kind of 24-hour medication in. So this is my daily medication. The point maybe for this doesn't really coincide with this slide, but it's also a lot of patients who then, if they have more pain, it's just another kind of checkpoint along the way to say, oh, I'm not walking around with my 60 tabs where if I have a little more pain, I may just take one. I have my 24-hour bottle. And then I can keep everything else at home, so I'm not worried about losing everything or having it taken. So I think that's also another good strategy. Just anything you can do to be creative to kind of help out. And then the last thing, kind of where and how to dispose of unused opioids. There are many safe options for this, for expired, unwanted, or unused medications, just to reduce the chance that someone else may accidentally get their hands on it or take it. The Disposal Act allowed kind of following the administered mail-back programs and maintain collectible receptacles at law enforcement, places, authorized manufacturers, distributors, some narcotic treatment programs, hospitals, clinics can do this too, and then some retail pharmacies. So just be sure that they're using authorized collection methods, though. That's one of the main points.
Have some plumbers,
Okay.
friends that would not like
Yeah,
that.
I know.
Flush the-
I know. I see that that's in there. That's why I kind of didn't really want to focus too much on that. Environmental factors. Okay, thanks, Robert. Oh, thank you. There we go. Get this out of your way. Can you hand me my notes?
I don't know if I'll use them, but
Over here.
yeah, just that. I doubt I'll use it, but, okay. We're going to talk about opioid use disorder now. So this is a very complex issue. People tell me all the time, patients tell me all the time that, how did I get to this situation? I just want something for my pain. And I think that does start that way, that opioid use disorder does not always start with pain, but it certainly can start with pain. There can be people with opioid use disorder that don't have pain. There can be people with pain who are on opioids who don't have opioid use disorder. And people can move from one of those groups to the other. Someone with pain and on opioids without opioid use disorder with continued ongoing use can then develop opioid use disorder as a sequela of that long-term use. Addiction. It's a powerful thing to talk to patients before you prescribe about the risks of opioids and include addiction as one of those risks. I think that all of us don't have to look very far to realize that we've been touched in some way or another by the disease of addiction. And I think it's important that we talk to our patients in those terms, that this is a disease. It's got psychological, environmental, and genetic components to it, but it's a disease nonetheless. I will share with you, my brother died from this disease. It was in 2014, he died. And I still have his last voicemail on my phone that I listen to every so often because we were close. He was 18 months younger than I am. And I tell my patients about that this is a disease, and I don't want to identify this disease of addiction because of I don't want to just point my finger and say, hey, you have this disease, go away. I don't treat this disease. I want to identify it so that I can help somebody with a disease, just like somebody with diabetes. I love the ASAM updated their disease, or their definition of the disease of addiction in I think this was 2019, might have been 2020. I think it's 2019, where they came up with their new addiction, new definition of addiction. I love how it's so optimistic because it's also true. Addiction is a treatable disease. It's complex, but it's treatable. Not only that, treatments for the disease of addiction are just as successful as treatments for other chronic diseases like diabetes. We couldn't always say that, but we have good treatments for the disease of addiction, and I think that we need to remember that. The practical definition that I use when I'm talking with my patients, after I show them on a slide, actually, this ASAM definition, and talk to them about the positiveness of that definition. And then I also talk about the 4 C's here when I'm talking to my patients, about compulsive drug use and loss of control and craving and continued use despite harm. I like this practical definition. I've not used it, but I do talk about continued harm to our patients. So that is a nice practical definition they have up there. But I just really talk about the 4 C's so that my patients can recognize that. I also go through the criteria for opioid use disorder with them. What I tell them is, you know, we don't use the term addiction as much anymore. We now use the term opioid use disorder, substance use disorder, alcohol use disorder, cocaine use disorder, instead of addiction to these individual substances. And I go through the criteria very briefly, but I say I just want you to know that this is out there because people look up opioids when they're on opioids, and if you see the term opioid use disorder, I want you to know what it is. So we talk about that from that perspective. Patients often have a misconception that physical dependence means addiction. Certainly people with addiction are often physically dependent, but not always. Okay, somebody maybe they don't have access to the drug to which they are addicted, and so they aren't necessarily physically dependent at that time. People can be tolerant and addicted, or tolerant and not addicted. So these terms are not synonymous. And I don't really like, I said earlier, aberrant or problematic behaviors. Aberrant problematic behaviors can be a symptom of addiction or not. They deserve additional, you know, looking at before you make that call. This says 10 to 26% of patients who are on chronic opioid therapy will develop the disease of addiction or opioid use disorder. I've seen studies where it says up to a third. In fact, a review article that cites the study that's 26%, which was a very large study, also cites the study that up to a third. And there are also other studies that say 10%. I think that it's hard sometimes when people are on opioids for chronic pain to identify that disease and because of that, it might be underestimated in some of those earlier studies. What do you look for when you're looking for the disease of addiction? People on high doses are more vulnerable for developing that disease. Prolonged use, they're more vulnerable. People that have low hedonic tone or they have a hard time finding joy in their life are more vulnerable. People with mental health disorders. There was a study published in 1990 in the Journal of the American Medical Association in 20,000 patients that showed that if somebody has a history of panic disorder, they are 3 times more likely to misuse a substance in the future. Schizophrenia 5 times, bipolar disorder 7 times, antisocial personality disorder 30 times. So clearly mental health issues can play a role in this. And notable, I think it's 19% of people in the United States have a mental health issue, according to at least one study, and 51% of opioid prescriptions go to that 19%. So sometimes people medicate themselves for their mental health disorders with opioid medications, which is not obviously appropriate. All right, so I'm not going to spend much time on this. Mathew Romankowski did a great job on talking about it. Clearly the periaqueductal gray is where the pain center is. This is where pain control happens. The nucleus accumbens is where euphoria occurs. Opioids can obviously go to both of those spots. The locus coeruleus is where physical dependence and with the withdrawal center occurs. And so if you abruptly stop an opioid, the noradrenergic tone increases and it's unopposed, and that's what leads to withdrawal. The cycle of substance abuse, I think, is really an important discussion to have. If you look at this, initially, you know, people are seeking that euphoria, they binge, they're intoxicated, but then there's kind of this downside of withdrawal and sometimes taking the medication just to keep themselves out of withdrawal. And then, of course, there's a preoccupation and anticipation of their next dose. That's kind of the cycle. These are the neurotransmitters that are really involved in this process. We won't go through each of those. Okay, medications for opioid use disorder, there are really 3. And they are life-saving. If you look at people who refuse medical therapy, medication therapy for their opioid use disorder, there's a 90% relapse. So medications for opioid use disorder are really important. And this statement, are we replacing one drug with another? I know lots of people have brought that up. I think we should look at it more like we're treating this drug with medication therapy. Are we treating this condition with medication therapy like we would other conditions treat with medication therapy?
What is Suboxone? Give up.
So Suboxone is buprenorphine.
Oh, sorry.
Yeah, sorry. So there are multiple buprenorphine products out there, some indicated for pain, some for opioid use disorder. Okay, talking about that, about buprenorphine, it's the most commonly prescribed medication for opioid use disorder that's prescribed. It's a partial agonist at the mu receptor. The key thing about this is it has a plateau effect for respiratory depression. That plateau isn't as robust for pain relief, which is probably a good thing. There's good efficacy with this medication, a good safety profile. Congress recently eliminated the requirement for an X-wave and dosage limit or in patient numbers. So it used to be, okay, you can have 30 patients this year and then you can add on. None of that is there anymore. All providers that are DEA licensed can prescribe buprenorphine for opioid use disorder. Always, all along, all providers that are DEA licensed could have prescribed buprenorphine for pain. But now it can be prescribed for both pain and opioid use disorder. There are sublingual forms. There are also, for pain, there's a patch form, as you know. So there's FDA-approved products for both opioid use disorder and for pain. We've talked about benzodiazepines a lot because of how incredibly risky this is when taken with opioids. We should avoid other substances. It's interesting with buprenorphine, I believe, and it's been a while since I looked at this literature, but 80% of the deaths that occur with buprenorphine are when benzodiazepines are on board because that you lose kind of that protective ceiling effect. Clearly, there are other central nervous system depressants that interact with opioids as well, like muscle relaxants and other central nervous system depressants, including sleep medications like Z-drugs. This statement, more than 30% of opioid overdoses involve benzodiazepines. That's true. With buprenorphine, it's higher because there's a lot fewer opioid overdoses without the benzodiazepines involved. So we should be using comprehensive substance use disorder evaluation forms or questionnaires. Some of those we've already talked about. When treating somebody with both pain and opioid use disorder, it becomes very challenging. Sometimes pain is the first thing that they have, and then later they develop opioid use disorder. Sometimes they come to you and they already have both of those issues. You have to address both. You don't just address one. Considering buprenorphine in that situation can be very powerful. Untreated pain can be a trigger for reactivation of opioid use disorder as they seek help. Be aware of that. Be aware of the need to avoid other problematic medications. We've talked about those at length. Having a multimodal treatment plan, an interdisciplinary approach with other providers like psychology can be helpful in both pain and dealing with the disease of addiction. We should be using monitoring, compliance monitoring throughout the process, but we should be doing that when we're treating patients with pain with opioids generally, but also when treating opioid use disorder. That includes such things as medication counting, urine drug screening, making sure that you have the patient sign a medication management agreement and all of that. Resources for treatment, SAMHSA, the Substance Abuse and Mental Health Services Administration, ASAM, the American Society of Addiction Medicine, and other organizations as listed here are resources. So kind of in summary, there's a place for opioids, but use caution. Multimodal therapy is really, really important. as part of the pain management plan, whether you're talking about pain or opioid use disorder. Screen for opioid use disorder by validated measures and realize that, your clinical impression is also important. Continually reassess your patients on opioids because they may not have had opioid use disorder when you first started seeing them 3 years ago, but now they do. Educating both the patient and the family is important. I always tell my patients when I do this opioid education, please bring to the patient, please bring your family members. I want them to be here, especially because a lengthy part of that discussion is what to do in case of overdose. And they're not going to be treating themselves. And so having family members involved, I think, is really important. If you suspect opioid use disorder, begin treatment.